It's 8 p.m. and I think we'll start the session with introductory remarks from Dr. Tushar Choksi, senior consultant anesthesiologist and a person who has contributed phenomenally to the growth of TCI and TIVA in this country, and a person who is known for putting up excellent infographics. And I deem it a privilege and pleasure to request Dr. Tushar Choksi to give the introductory remarks.
Thank you, Dr. Balavenkat. Ladies and gentlemen, welcome to our Point of Care Ultrasound Focus webinar, a symposium bringing together the expertise of 5 distinguished speakers under the guidance of 3 dedicated moderators. In the next few minutes, we will embark on a journey to unlock the potential of focus in healthcare. So get ready for the enlightening experience. I will not take more time and I will hand over to Dr. Balavenkat.
Thank you very much, Dr. Tushar Choksi. We start this webinar in such a happy note and a proud moment for every Indian for the phenomenal success that our scientists have accomplished from the Indian Space Research Organization in making Chandrayaan land in the south pole of the moon, the first ever time it has happened. In spite of the phenomenal challenges that are posed in landing Chandrayaan in the south pole, India and the Indian scientist, Indian mind has accomplished it. So at this juncture, we need to take a cue and inspiration from the hundreds of scientists who worked on it. As we feel very proud and very happy to be an Indian at this juncture, we also need to introspect and tell ourselves we should make our country proud by what we deliver as a professional to the healthcare. I think like what the country is feeling proud of the ISRO scientists, the country should feel proud of the professionals, the anesthesiologists of this country for their phenomenal contribution to patient safety, data collection, and pushing this nation forward in the right and appropriate direction. I'm sure we'll be able to do that together. Today, we have a very, very important webinar on point of care ultrasound. If we look at the genesis of anesthesia and anesthesiologists were considered a person who was responsible to provide anesthetic care inside the operating room. And the minute the surgery got over, hand over the patient to the surgical colleague and leave. Gone are those days. We are moving into a new era of practice of anesthesiology, and slowly anesthesiologists are becoming perioperative physicians, where they embark on the journey of optimizing a sick patient in the preoperative period, give them a safe anesthesia intraoperative period, and look after them in the postoperative period. And they assure that the morbidity and, of course, the mortality is minimized even in the critically ill patients, even when they come with end organ damage. To aid them to resolve issues on the bedside, most of the times, the physicians 2 decades ago depended on their experience and expertise and tried to extrapolate the clinical symptoms and signs to come to a conclusion which may not be true all the time. Seeing is believing, and one equipment which has revolutionized the practice of intensive care and perioperative care is the point of care ultrasound. Thanks to the advent of this machinery into the fraternity of anesthesia, which has completely changed the way as a physician looks at the patient. And to quote, I work in a large tertiary care referral center for trauma, orthopedics, reconstructive microvascular surgery, and plastic surgery. Here, we deal with a lot of polytrauma victims. And I'm very happy to share the anesthesiologist and the Department of Anesthesia looks after the patient when they come in with a major polytrauma, and the EFAST and looking at the IVC, looking at the lung. Everything is done by the anesthesiologist. Not a single minute is wasted on calling the radiologist, waiting for them to come. Would explain this with a single case scenario. Here was a 68-year-old lady run over by a four-wheeler, and she comes gasping into the emergency room, immediately shifted to in our hospital. The philosophy is they are shifted into the ante-room of the operating theatre, which is the place where we resuscitate, where there is availability of the top consultant in anesthesia, the top surgical team, and the paramedic, and the ECG, X-ray, ultrasound, everything is available in the resus room. So this patient, when he came, was in jaw breathing. So the process of the primary survey, including airway with cervical spine control, breathing with ventilation and support circulation started. And within seconds, when you started the initial thing, within seconds, the anesthesiologist puts the probe to see where he's bleeding. Definitely, it looked like hemorrhagic shock. And initially, as the process of resuscitation was going on, the pressures, which was not palpable, slowly climbed up to 50 to 60 systolic. And again, we couldn't see anything. But when the pressures moved up to 80, a repeat scan in another 5 to 6 minutes showed that there was a splenic rupture and the patient was profoundly bleeding inside. And the next thing was a resuscitative laparotomy, patient being shifted into the operating room immediately. So this was only few minutes before death, and it became prudent that the consultant there had the potential to do a point of care ultrasound, find out that there was a splenic rupture, patient going for a laparotomy, and almost a massive transfusion protocol initiated. And the surgical time was about 2.5 hours, after which patient was ventilated overnight and extubated the next day. Here, if you analyze that, every second that we would have missed would have resulted the difference between life and death. Hence, it becomes extremely essential that we possess certain important aspects of point-of-care ultrasound for our day-to-day clinical practice and bedside diagnosis. To enumerate on this, we have excellent faculties, 5 of them who are doing regularly the point-of-care ultrasound. I have great pleasure in introducing, when I introduce, can you just unmute yourself and the panelist can say and greet the delegates. And I have great pleasure in introducing the anchor and the person who started the whole process of putting things together, Dr. Subramanyam S. Mahankali. And he is a senior consultant and lead anesthesiologist at Aster RV Hospital, Bengaluru, India. He's got special interest in point-of-care ultrasound, TIVA, TCI, regional blocks, transplant anesthesia, and very keen on promoting patient safety. He's a member of the Board of Studies of Academy of Regional Anesthesia of India, founder member of TCI and TIVA Society of India, has 23 peer-reviewed publications and 2 editorials, 5 textbook chapters, and is the editor of an upcoming textbook of anesthesia. Thank you so much, Dr. Subramanyam Mahankali, for making this happen today and for sharing the thoughts and knowledge with everyone. Would you like to quote anything regarding your stint with this? You want to quote something, an anecdote, before I move on to the next panelist?
Thank you, sir. It's a pleasure to be on this stage. As we just witnessed, our lander landing in Moon, it was almost precise to the minute. We are on the way to achieve precision and personalization in anesthesia. Ultrasound, use of it in our everyday practice will help us go closer to it. I started having ultrasound machine in my hand probably a decade, slightly 2 decades and more, probably 21 years now. A lot of understanding, a lot of growth has happened, both in the in our experiences and how the machines have changed as well. With all the faculty here, we will try to put things together so that we can start using it in a structured way and make a good use of it. Thank you, sir.
Yeah, thank you so much, Dr. Subramanyam Mahankali. And we have great pleasure in having Dr. Madan Narayanan, who is a consultant in anesthesia and ICU at Frimley Park Hospital, United Kingdom. He has got special interest in regional anesthesia, in the intensive care unit, and special interest in airway and lung ultrasonography. He is also an examiner for EDRA and EDIAC. He is a honorary lecturer for MSc Regional Anesthesia for the University of East Anglia. He is a program director, International Fellowship in Regional Anesthesia at Frimley Park Hospital. He is a honorary visiting professor for anesthesia in India and Ukraine. Dr. Madan, thank you so much for joining us and for sharing your valuable insights and inputs on such an important topic.
Thank you very much, Dr. Bala and Dr. Subra, for inviting me today. I think we got a very distinguished panel who will be able to enlighten on the benefits of point-of-care ultrasound in pretty much every aspect of our practice. I hope I'll be able to share some of my insights into use in airway ultrasound. Thank you.
Thank you so much, Dr. Madan. I have great pleasure in introducing Dr. Amit Dixit, who is a consultant anesthesiologist in the Ruby Hall Clinic, Pune. He is a member of the Board of Studies of Academy of Regional Anesthesia of India. He is a member of the Perioperative Intensive Care Echocardiography and Ultrasound Foundation. He's been instructor for both the basic and advanced echocardiography course, faculty lead for basic and advanced Pocus workshops. He's a regional anesthesia fellowship under the guidance of a regional fellowship guide under MUHS and AWARE India. He's also a teacher for DNB and a PG guide. He has contributed chapters in regional anesthesia and Pocus handbook. He has got articles in index journals, contributed videos in Pocus Today app, an initiative by National University of Singapore. Thank you so much, Amit Dixit, for giving your valuable inputs today. Dr. Amit?
Yeah, thank you, Bala sir. It's a privilege to be part of this gathering. Sir is my teacher, and I'm student of Dr. Balavenkat sir, and it all started from that area. And we are talking about scientific development of our nation. We are talking about Atmanirbhar Bharat. So today with Pocus, at the end of this session, we will have Atmanirbhar anesthetist also. So if we become Atmanirbhar ourselves, I think the country will automatically become Atmanirbhar. Thank you. So we'll move.
Thank you so much, Amit. We are really happy and proud to see your accomplishment, and also very happy to know that you are passionate in teaching people and enriching them with all that you have gathered over years. Thank you so much for being a part of this session. I have great pleasure in introducing Dr. Divesh Arora, who is the Director and Head of Department of Anesthesia and Operational Theatre Services at the Asian Hospital, Faridabad. And he's a DNB teacher and examiner. He's an NABH assessor. He's a Green OT assessor. He's got 14 national and international publications, 8 book chapters. He's past president of the Haryana ISA State Branch. And also he's a faculty for various workshops in ultrasound-guided regional anesthesia and point-of-care ultrasound. His special interest is USGRA, Pocus, lung ventilation strategies, quality and safety in anesthesia and perioperative care. And I'm very happy to have Dr. Divesh Arora with us today.
Good evening, ladies and gentlemen. Thank you, Dr. Bala sir, for that kind introduction. I feel as anesthesiologists, as perioperative physicians, we are rightly positioned to use sonography for performing regional anesthesia as well as Pocus. Looking forward to an enriching session. Thank you, sir.
Thank you so much, Dr. Divesh, for joining us today. Not the last and not the least, but a person who has phenomenally contributed for the critical care development in this country. I have great pleasure in introducing Dr. Sunil Karanth, who is the chairman of Critical Care Services, Manipal Health Enterprises Private Limited. He currently serves as the head of the department and senior intensivist of the Manipal Hospital, Bangalore. He's an adjunct professor in critical care medicine at Manipal University. He's the chair of the Hospital Infection Control Committee, member of the Medical Advisory Board, chair of Code Blue Committee, is a member of the Pharmacotherapeutic Committee, is a past chairperson and treasurer of Bangalore Society of the Indian Society of Critical Care Medicine, is a senior examiner and teacher for the IDCCM and IFCCM, senior examiner for National Board of Examination. He was a member of the Karnataka State Critical Care Support Team, is winner of several accolades, including Namma Bangalore Award for Healthcare in 2022. His areas of interest are trauma and neurocritical care, poisoning, obstetric critical care, extracorporeal therapy, and a person who using the point of care ultrasound extensively in the intensive care unit. So here we have the conglomeration of 5 eminent specialists who use point of care ultrasound in their routine clinical practice. And I'm sure this next 1.5 to 2 hours would be a knowledge transfer in equipping and also sensitizing every delegate who has come from India and from outside India. I hear there are a lot of participants who have logged in from Africa and Middle East today. And it's such a pleasure to welcome all the delegates who have come from far and wide. And I also would wanted to instruct the delegates, as this panelists are speaking, if you have any doubts, please address the question to the panelist. Please type it in the chat box, and we will see whether the panelist could answer to your questions as the speakers are speaking. And some of the questions we can take up later, but I would strongly encourage any questions and doubts that you have, keep on posting it in the chat box. So with this introduction, I hand over the proceeding to Dr. Subramanyam Mahankali to take this session forward.
Thank you very much, sir. Now, one of our co-moderators, Dr. Shishir, because of logistical difficulties, he was not able to be in time. So I'll just introduce some of the things and then go to the speakers. One of the things which you would realize is ultrasound in anesthesia is not uncharted. There is a framework which is being developed. There is a structure which is there. And one most important thing what we feel is every Pocus examination should precede by a question. What is the question you have in mind? And using which Pocus tool you can answer that question. And how to go about. People have created a framework, what is known as an IAM Framework. I'll just briefly share this slide about IAM Framework. This was with respect to the gastric ultrasound, but it's the framework holds good for almost every kind of Pocus tool which we want to use. Now, as I told, IAM stands for I stands for indication, A for acquisition, I for interpretation, and M for medical decision making. So in a sense, when all the Pocus tools, when we want to use, we have to have a question in mind, use the appropriate Pocus tool, and use that Pocus tool in this framework so that there's a structure and we get an answer at the end and use it for medical decision making. Okay. For example, in case, let's say you want to do a gastric ultrasound, you have to have an indication. So that means there is some doubt in mind whether the stomach is empty or not. And in that case, you can use this tool to examine a particular part of the stomach. And that how to examine which part of the stomach to look at and how to acquire the images is about acquisition and which position to acquire, which settings to use, which part of the stomach to use. And next is interpretation. So in this course of the talk, in the next 1.5 hours, you will see how to interpret those images. In the Pocus, the important thing is analyzing the patterns, getting used to the patterns. So these form an important role when we are using ultrasound in our everyday practice as a Pocus tool. And I will go through in details as when we come to the gastric ultrasound as well. Every speaker, you will see that he will use an indication, he will use how to acquire the image, how to interpret those images, and how to use them in your decision making. Because ultimately, the Pocus is about helping you making. So it is what we call as decision support systems. So this forms an important part of the decision support mechanism. And with that, we can make an appropriate decision, use it for bettering the patient care and making sure our patient care is to the best possible extent. With that, I will come to this IAM framework. And I will welcome the first speaker of the day, Dr. Madan Narayanan, all the way from UK, to speak about how to use ultrasonography in assessing the airway and how to use it as a focus tool. Thank you, Dr. Madan.
Thank you very much, Dr. Subra. I will start sharing my screen now. So, share. Okay. Right. Today, I will be talking about airway ultrasound. As Dr. Subra and Dr. Bala had given an introduction, I'm from the UK. I work in this hospital, which is in the southwest of England, in Frimley Park Hospital. Acknowledgements, I use some of these images from ANSO, and some of the other images and videos are from my own repository. There's no other conflict of interest to declare. Why do an airway ultrasound? The airway is easily accessible. The examination of the airway can be performed pretty quickly, and use of an ultrasound facilitates assessment of the airway, portable at the bedside, at the point of care, to guide your decision making. There's easy and ubiquitous availability, especially in our country, of machines. It's a very easy framework and technique to learn, and there's no radiation involved, so which means that you could repeat the examination as much as necessary. So there are a few key features that you need to know about ultrasound and air. Air has low density, so as a consequence, it's got a high attenuation for ultrasound, which means it scatters away the ultrasound beam, and you are bound to see a lot of artifacts, and hence you got to know how to interpret artifacts in the world of airway ultrasound. This is a major audit work which was done in the UK about airway complications following anesthesia. And what this audit project showed was that the complications are all related to poor airway assessment. And at least in the ICU or the emergency department, where major airway events happen, there is inadequate time or ability to do an airway assessment, especially when the patient's cognitive level is low. And in these areas, the outcome of some of these airway mishaps can be quite fatal and cause long-term consequences. As we're all aware, this is the modified Mallampati classification. The person on the left is Dr. Mallampati. We all know that this test for assessment of difficulty of airway intubation has got good specificity, which means that when the test is negative, you're extremely unlikely to have a difficult intubation. But its sensitivity, when a person has a difficult intubation, does this patient have the same signs, or is the test positive, is very less. So which means use of this test as a screening tool to identify a difficult intubation is pretty useless. This is where airway ultrasound shows its value. So there have been a lot of validation studies using of different parameters where the use of ultrasound to study the width of the tongue, the volume of the tongue, the volume of the floor of the mouth, the different distances like hyomental distance or distance to the epiglottis from skin. These have all been used as parameters to identify difficulty in managing the airway. So again, these are having flaws. They got poorer sensitivity, but their specificity is reasonably high, higher than the classical airway examinations that we tend to do. Use of combination of tests increases the predictive value. And again, negative predictive value is much better with these tests. So this is again another study which was using airway ultrasound to measure the thickness of the tongue base and using hyomental distance as well. So what they showed was the sensitivity and specificity is close to around 0.75 for a tongue thickness of more than 6 centimeters. So, and the greater the ratio of tongue thickness to the thyromental distance, you have a greater sensitivity and specificity for identifying a person with a difficult airway. So, so it's an easy bedside point of care objective test which you'll be able to use to identify difficult airways or difficult intubation. Multiple systematic reviews have come across which all show that more than 28 measurements are available, which have all been used in different studies. Ultrasound is still not regularly used in airway assessment. We need to follow validated protocols and use standardized measurement techniques at specific levels. Use of a combination of parameters like the hyomental distance or thyromental distance in addition to tongue thickness. So using more than one parameter in making an assessment improves your sensitivity, specificity. And at the time, most useful ones are tongue thickness and the hyomental distance. They all have higher negative predictive values, which means when the test is negative, you are extremely unlikely to have a difficult intubation. So how would you perform an airway ultrasound to assess the airway? You do it in a supine position with the head and the neck extended with a pillow under the neck. You use a curvilinear probe with a depth setting of between 5 and 8 centimeters and use the MSK settings. Use a sagittal view in the midline and you freeze the image and make the appropriate measurements, and then use validated tools for making your predictions. One of the other outcome measurements or the recommendations following the major airway complications audit was the decisions about poor airway planning, where a person was identified to have a difficult airway, but then there was a failure to plan for a definitive management. A fail to plan means your plan to fail. In this article, which showed the accuracy of surface landmarks for cannula cricothyrotomy, it was a very poor accuracy among experienced anesthetists to identify the cricothyroid membrane. Only 30% were able to identify it accurately, and only 10% could place a mark in the midline. Similarly, use of any other landmark techniques, such as palpation, using specific measures like 4 finger breadths above the sternal notch, or using the neck creases, are all bound with inaccuracies. This is where point-of-care ultrasound has got a very high sensitivity, specificity, or accuracy in predicting the cricothyroid membrane. So in this study, which looked at digital palpation versus ultrasound in the measurement of identifying the cricothyroid membrane in obese women, showed that only the digital palpation was identified in only 39% of the obese parturients, and 71% in non-obese patients, whereas 100% you could be able to identify with the ultrasound. Similarly, gender has got a big difference. Males have got a prominent thyroid cartilage, and the angle is much more prominent between the thyroid and the cricoid. So hence you're able to identify it much better in men compared to women. And in obese women, it is probably much easier to identify the cricothyroid membrane. And when there is difficulty, especially if the patient's had previous surgery, radiotherapy, landmark techniques are much inferior when you compare it with ultrasound, which has got a 10-fold greater accuracy in predicting the cricothyroid membrane, especially when compared it with CT. How do we do an airway ultrasound? We need to do with the patient in the supine position with the head and neck extended, same position as how you do an airway assessment. But here you use a high-frequency linear probe and use the MSK or small parts settings. So you do the assessment at 4 different levels. One is at the level of the thyroid cartilage, then cricothyroid membrane, then cricoid cartilage, or finally at the level of the tracheal rings. You can also do the assessment in the sagittal position, which is in the midline. So each of these have got different utilities, which we'll come to see as we go along. So what do you see first at the scan at the level of the thyroid cartilage? So here you could see the strap muscles, and then you could see the V-shaped thyroid cartilage in the midline. So behind the thyroid cartilage, you'll be able to see the false vocal cords, and which is useful for assessment of vocal cord function, which we'll see later of its utilities. When you go a little bit inferior or caudate, you'll come to the level of the cricothyroid membrane. So when a transverse view with a linear probe is done in the midline at the level of the cricothyroid membrane, what you'll see is an image like this. In this image, what you can see is the strap muscles again, and the cricothyroid membrane at the junction of the strap muscles. Below that, you see a bright white line, which is actually the air mucosal interface. Below the air mucosal interface, all you see is just artifacts. And these artifacts are due to reverberation artifacts. As I said to you before, the junction between cartilage and mucosa with air is a highly reflective surface. It produces to and fro reverberation artifacts. And you could see silhouette of the cricoid cartilage behind. As you move the probe a bit more caudate, what you'll see is again the strap muscles. You could see a big signet ring cricoid cartilage and the bright white line of the air mucosal interface. Behind this, you see a mirror image artifact, which technically is not the cricoid cartilage. It is actually a lot of artifacts by the to and fro reflections. And as you go even more caudate, you'll start to see the appearance of the thyroid gland. So again, the strap muscles, the presence of the thyroid gland, the thinner tracheal rings compared to the cricoid cartilage, and they are much more wider. And you see the air mucosal interface and the artifacts. So if you place the probe in the sagittal position, you'll see a long view of all the structures. Here, this is a cephalocordad. The left of the screen is cephalad, and the right of the screen is chordad. You could see the thyroid cartilage, the cricoid cartilage, and in between them is the cricothyroid membrane, and then a pearl of strings, string of pearls, where you see all the tracheal rings, which could be counted 1 to 5 in this image. And then you see the cricothyroid membrane and the air mucosal interface just behind it. It is not a very difficult scan to learn. In a 2-hour training session with around 20 scans, novices have an 88% sensitivity, an 88% accuracy and a success rate. And within half a minute, you're able to identify all the structures. And this is repeated even at 3 months, you have an 86% success rate at identifying these structures, which means the knowledge is still retained for a long time. Then the audit also showed that failure to interpret a capnograph trace following anesthesia showed that there are many esophageal intubations which go unrecognized under anesthesia. And in many places where end-tidal carbon dioxide is not available, or the end-tidal carbon dioxide cannot be as good as a normal anesthetized patient, like in a cardiac arrest, there is a potential for the use of the ultrasound. So in this systematic review, ultrasound, when was used to, again, compared with gold standard of end-tidal carbon dioxide, showed a sensitivity of 0.98 and a specificity of 0.95, which means it's very accurate for identifying a tracheal or esophageal intubation. And in the subgroup analysis, where you use the ultrasound, who does the ultrasound, or what transducer you use does not really matter in finding the outcome. So ultrasound, even in a cardiac arrest situation, has got a really high sensitivity, but its specificity slightly drops down in that scenario. So it is a useful tool, even in a difficult scenario where the end-tidal carbon dioxide may not be as high as in a normal anesthetized patient. So how do you do it? You place the probe transversely or slightly towards the left above the suprasternal notch. So here, what you see is the, as I showed you before, the tracheal rings, and then the esophagus, which is like a ovoid structure just behind the level of the tracheal rings. So if a tube is passed behind onto the esophagus, what you see is a double bubble sign. So you have 2 bubbles. The first bubble is of the trachea, the second bubble is of the tube in the esophagus. But if the tube passes on the left-hand side into the trachea, you will lose the view of the esophagus, and then the trachea appears like a bullet sign, where the plastic tube over there, or the inflated cuff, creates a vertically vertical lines which are artifacts behind which we cannot see anything. So that is called the bullet sign. So if you use any of these signs, the double bubble sign or the bullet sign, or to see whether the tube's gone into the lung and the lung is ventilating, which is the lung sliding or movement of the diaphragm, any of these tests can be used with a reasonably high sensitivity and specificity for identifying tracheal tube placement. So in this video, you'll be able to see the placement of a tube, which the trachea is seen, and then you can see the esophagus first behind. The placement of the tube in the esophagus causes the double bubble sign, and then the tube is then withdrawn and placed in the trachea, where you could see a movement artifact, which is actually called the snowstorm sign, when the tube goes first into the trachea, and then you get the bullet sign. In addition to confirming tracheal placement, cricothyroid membrane, you could also use it to perform airway blocks, where the probe is placed at the side of the neck, between the hyoid and the thyroid cartilage, and identifying the structures, where on the right side you could see the hyoid, and then you'll see the thyroid cartilage over here, and between them is the thyrohyoid membrane. The superior laryngeal nerve just lies on the thyrohyoid membrane and can be easily blocked over there with a few mils of local anesthetic. This could be used to block the superior laryngeal nerve for producing airway anesthesia in a difficult intubation. In pediatrics, estimation of the size of the tube is a very tricky scenario, where if you use a tube which is too big, you can cause airway trauma, which then cause postoperative stridor. If you use a tube which is smaller, you can cause inadequate ventilation and a lot of leak. So assessment of the size of the tube is quite an important factor. ultrasound has been shown to have a very good accuracy in identifying the best fit tube and producing the least amount of leak. It had better agreement than height-based, age-based, or weight-based assessment and formulas. Another contentious area is the efficacy of the cricoid pressure. An ultrasound can be used to assess the efficacy of cricoid pressure during rapid sequence induction of anesthesia in a patient with full stomach. So in this image, you could see that there are three patterns which could be seen. A first pattern is where the esophagus is behind the trachea. The second pattern is where the esophagus is partly behind the trachea. And then the third pattern is where the esophagus is totally towards one side of the trachea, which could all be identified on ultrasound. So what it showed was, with the use of cricoid pressure, we actually push the esophagus more towards the left-hand side. As you can see from these three tables, all you can see is that the trachea is behind the esophagus is behind the trachea, but then with the cricoid pressure, it moves more towards the left. 70% with the application of cricoid pressure, the trachea moves towards the left. This shows the validity of cricoid pressure in rapid sequence induction. Another area where ultrasound could be used is in assessment of vocal cord movement, assessment of vocal cord dysfunction, especially after thyroid surgery or postoperative causes of hoarseness to identify airway edema. And in this video, you can see that when the probe is placed on the thyroid cartilage, you could see the cords being moving when the patient phonates. And a paramedian position or a midline position can be used to assess postoperative vocal cord dysfunction without having to put a nasoendoscope. And when you put that to the test, the sensitivity and specificity of laryngeal ultrasound ranges, and it's observer dependent and patient dependent as well. And the quality of the images determine the sensitivity and specificity. So they range from 50 to around 90%. In intensive care, the ultrasound has got a lot of uses, especially in the airway. For percutaneous dilatational tracheostomy, especially when you want to place the tracheostomy between the second and the fourth rings. If you place it too high, you have a high risk of causing subglottic stenosis. If you place it too low, you can cause complications like tracheoinnominate fistula. So 2 to 4 rings is where you got to place the tracheostomy. Ultrasound helps in accurate identification of the number of the tracheal rings to guide your placement. In addition, you could look for vascularity and avoid the vessels which come in your way when you perform a tracheostomy. Use of a color flow Doppler helps you in judging where the vessels are and planning the trajectory of your needle. You can also see subclinical pretracheal masses, which can move your trachea towards one side, where in this patient, the patient's got a tracheal thyroid lesion, which displaces the trachea to the left. So it helps in more accurate midline placement of tracheostomies. So in this study, which looked at multiple systematic reviews and studies, which looked at the use of ultrasound, showed that you have greater midline punctures, fewer punctures, shorter time to do a tracheostomy, and accurate prediction of the rings, predicted ring space. You also have much lesser complications with performance of ultrasound for performing tracheostomies, and it is my routine practice, especially in patients who got coagulopathy, obesity, difficult airway, or have a C-spine problem, or are on high respiratory support, which is beyond 50% oxygen. In summary, uses during percutaneous tracheostomy, it also helps in endotracheal tube withdrawal. When you want to withdraw the tube, you could place real-time ultrasound to guide where to stop the withdrawal of the tube when you place the tracheostomy. So it helps guide the punctures, and you can also identify the guide wire enter into the trachea. And post-tracheostomy, you can confirm bilateral lung sliding even before you aggressively ventilate the patient, or even check for pneumothorax, which will come to in the lung ultrasound teaching. Assessment of swallow is another potential area where you can use the ultrasound. In this video, you could see that the esophagus, which is on the left side of the screen, you could see the upward movement of the esophagus and the downward propulsion of swallowed contents, which was actually air bubbles or saliva. And this could be used as a function for assessment of a swallow, especially in patients who have had tracheostomies who are being decannulated in ICU. There are many validated tools available. It is still not very common practice. It helps you in assessment of these, the extent of movement of the laryngeal and pretracheal muscles. It also helps in assessment of vocal cord broad movements and silent aspirations of two secretions behind the vallecula. So these are the multiple uses of airway ultrasound in anesthesia and in ICU. Right, I would welcome any questions. Thank you.
Thank you, Dr. Madan. Would you be there around for the end to answer the questions?
Yes, Dr. Bala, I'll be here.
Yeah, okay. So we'll take the questions in the last. But meanwhile, you can see the chat box where the question answer box where the few Q&As have come, which you can possibly answer directly to everyone.
Okay, perfect. Thank you.
Yeah, back to Dr. Subramanyam.
Thank you, sir. Thank you, Dr. Madan. To recap what you just said, it has an extensive role in the emergency room, in the anesthetic assessment of the airway, and also has potentially plenty of uses in the ICU as well, right? And it not only helps you predict the difficult intubation, you can also plan your intubation. You can look at the, in case if it's going to be difficult, you can look at the front of the neck axis and assessing the tube placement, emergency intubations, and a lot of other roles. Right? Wonderful. Thank you very much. As Dr. Bala requested, if you stay till the end, we will have questions directly from the audience, and that would be really helpful. Thank you. If you can stop sharing the screen, Dr. Madan. Sir, next we have Dr. Amit online, sir.
Yeah.
It's a pleasure to welcome Dr. Amit here. There are a few people around the world who I generally say their brains are larger than the skull, and not who is extremely committed. And in the last half a decade or a decade, he's one of those making a tremendous difference, not only in assessing the knowledge available, making sure it reaches the right people. Thank you, Dr. Amit, for being part of this program. And I'm sure everyone, by the end of your talk, will be excited, want to hold the echo probe in the hand. Thank you.
Yeah, thank you very much, Dr. Subbu sir. And I think the topic given to me today is basic fate, and the organizers have asked me to sensitize the audience with the fate. So initially the acknowledgements, my mentor Dr. Vinayak Desurkar, who taught me basics of echocardiography, and with him we run this basic course on echocardiography as well as advanced course. Dr. Deepak Borde is also a very good teacher, and he's my batchmate, and we together run all these Pocus workshop. And in my today's presentation, he actually has shared some of his slides, and he really emphasized me that please share these, they are very useful, and I'm really glad and happy, and I'll be sharing them with you. I also acknowledge the contribution of my department and my institution. In my department, we have 5 ultrasound machines. Each one is with echo probe. They are all high-end machines. All my department colleagues, all consultant colleagues are echo certified. So we have a very wonderful department. Greetings to you all from Ruby Hall Clinic. It's a 750-bedded multi-speciality hospital. It has, we run a fellowship program in regional anesthesia. And I have included Pocus as integral part of our fellowship training. So all my fellows are also certified in echocardiography training. So what about my journey? So as the organizers also have emphasized that please share your experience. So this was way back, 10 years back, and then I was a junior consultant, and late night I got a call for an emergency, spine surgery, cervical spine surgery, and it was very, at 10 p.m. and it was a busy day of Diwali, and in India, in Diwali, you will have a lot of traffic jams and everything. So somehow I reached the hospital and I could see a patient with ECG changes, a lot of bradycardia, and history of diabetes, hypertension, IHD. The echo machine, I said, let's I'll get a echo report. and they said that echocardiographer, the cardiologists are not available. The echocardiographer will take good amount of time to reach the hospital. So there was a machine with an echo probe. There was a patient next to that, echo machine, and the surgeon were hurrying up, like, please shift the patient. And finally, we were pushed, and we shifted that patient because it was an emergency surgery, trauma patient, and they said cervical spine, maybe head injury, and all those things were there. And I was like, if I have some idea about the echocardiography assessment of this patient, I can risk stratify very easily whether I want to put central line, whether I want to put arterial line. Am I supposed to call additional help? How bad is this patient? It was very, very difficult. And with that amount of distress, I completed that case. I took a lot of effort in managing. Patient went home well. But that has transformed me, that there is a machine, there is an ultrasound machine, there is a probe, and why can't we, equip ourselves so that at least for the safety of our own patient and, for better anesthesia management, we should have that good knowledge. And, 10 years down the line, it has changed dramatically. Last month I got a call from a surgeon, and there was this 12-year-old child for acute appendicitis, and it's emergency surgery. And the pediatrician said that there is some murmur there, and probably it needs advanced assessment by a cardiologist and everything. And it was an emergency case. So the surgeon requested, could you please come here and settle this? Then we have asked for a machine. We did a quick echo, and looking at those echo images, I was very well convinced that there is no need for further assessment. It was probably a hemic murmur, and all the views could show that the baby is absolutely fine. So things have changed for good, and it has given us confidence. We respect the opinion of cardiologists, but yes, we can identify which patient is high risk, which patient needs further evaluation. And at least nowadays in my practice, I can very well use it. And how effectively I use it, I'll be demonstrating with few of the examples. Now, this is very important how we are progressing in anesthesia. We all are managing ASA 1, 2, 3, 4 patients, and they are coming up for variety of surgeries. So we need some upgradation in monitoring. And as we are moving more and more towards left-hand side and upper corner, probably not only central line and art line, but probably more invasive, something like SVR, PVR monitoring, probably LVOT, BTI, cardiac output assessment. So this is all very, very important when we are dealing with critically ill patients. And I think echo is a very, very cost-effective, easy skill set. And if you have that basic skill set, you can use it in all 4 quadrants, and right from ASA 1 to ASA 4, minor surgery to major surgery, and even for anesthesia in remote locations like endoscopy, CT, and MRI. It gives us a lot of peace, a lot of confidence, and it enhances the safety of all our patients. So if you want to put an art line and attach, nowadays many companies do provide these type of gadgets, but the transducers are very costly. At least in India, we have the cost is around about 10,000. So I think a Schwann catheter or a use of these technologies with art line and all that, the easier bet would be why not use a probe. And we have assessed heart in all all these situations, and it has given us confidence that yes, we can provide safer anesthesia to these patients. So what is Pocus training? I think my previous speaker already have covered some aspect of it, as it is a question with binary answer in form of yes or no. It is time sensitive, and it is only limited evaluation. So we are not here to replace radiologist, cardiologist. There is a very specific question: why my patient has tachycardia? Why my patient has hypotension? Am I dealing with pneumothorax? Am I dealing with pulmonary embolism? Is it cardiac tamponade? Very specific question, and we are doing limited evaluation in a very time-sensitive way. So there can be level of echo training, and we are here probably lower down where we are risk stratifying our patients, whether they need further assessment and further evaluation, and we can predict which patients are not as of now we should not be taking those patients. So at least if we could develop this type of a skill set with this basic emergency echo, I think it will give us a lot of confidence, and it will be beneficial for all of us. So where is the evidence? Now, American Society of Regional Anesthesia has come up with good amount of evidence, and it has suggested if you do minimum 50 supervised studies, and it will give you a good confidence in doing a focused cardiac ultrasound. Me and Dr. Desurkar sir are running these courses on a regular basis. It's a structured course with e-learning material, 100% hands-on experience, and then followed by an exit exam. So if as an anesthetist, we all think of doing a ACLS or a BLS course or an ATLS course, I think the time has come that we all should do basic and advanced FATE courses, that echo courses. So already it has been published, validated studies and used for all general anesthetists. So gone are the days where we are talking only about physical examination with inspection, palpation, percussion. Now are the days of insonation. So we need a echo probe. So basic FATE card will teach you about 4 basic positions like subcostal 4-chamber, apical 4-chamber, parasternal long and short axis. And now it has included lung aspect as well. So if we can master at least 4 basic views, we will be able to pick up many life-threatening conditions. And as I have highlighted, subcostal 4-chamber is position 1. Position 2 is apical 4-chamber. Position 3 is parasternal long and short axis. And position 4 is for lung and diaphragm. So these are the views. I will be showing few of the videos. So what exactly we are trying to rule out? So we cannot wait for a cardiologist or a pulmonologist, somebody else to tell us that the patient has pulmonary embolism, or patient has cardiac tamponade, patient is in MI, or patient is severely hypovolemic. It's a very yes or no question, a question with binary answer in form of yes or no, and we have to decide then and there so as to have some dent on the outcome. So causes of shock and hypotension which can happen peri-operatively are pulmonary embolism, tamponade, severe hypotension, and MI. And as the lungs are included in basic FATE, we can also rule out pneumothorax, massive pleural effusion, and pulmonary edema. So if these conditions are picked up, I think we are definitely saving lives. We feel confident. Otherwise, something like pulmonary embolism is an autopsy diagnosis. So we'll start with position 1, and position 1 is you can see the probe is placed in the epigastric area. The orientation marker, this grip is a screwdriver grip, and you can just put the tail up and down in that way, and you can see the orientation marker is towards the left shoulder. Now the probe is rotated anti-clockwise to open up IVC. So you can very well see the subcostal 4-chamber, the opening up of IVC, and once the IVC is opened up, you can assess the fluid status of this patient. Now there are AI-enabled technologies, something like as auto IVC. It will tell you what is the maximum diameter, minimum diameter, and what is the collapsibility index, and whether the patient needs fluid or not. We cover all these aspects in greater details in our FATE course. So if the diameter is nearing 2.1, we don't need fluids. If it is really less, then we need to give fluids. So this is a subcostal 4-chamber, and even if we get one good view, we can see where is RA, where is RV, and then we can definitely look at IVC. So moving to the, how my PGs are using it, to start with. We put a lot of central lines in our daily routine practice, and this is a swirl sign which is positive confirmation of central line tip in RA. If the swirl sign is positive in less than 2 seconds, then the central line tip is in RA, and we do not do any X-ray for these patients. If it is more than 2 seconds, then probably we also have to look at the ipsilateral axillary vein or a contralateral IJV and identify where the tip has gone. And it is very good idea. Once we place the guide wire, even we can see the guide wire in RA before we dilate it. So 2 days back we had a patient and they had this permacath insertion, and catheter has gone through SVC into the pericardium. And then the patient was shifted to interventional radiology suite, and then it was removed, and then a covered stent on SVC. So everyone is aware that so many complications can happen, and it can be very well avoided with an ultrasound-guided, ultrasound-assisted central line placement. We definitely document it as it on paper that limited evaluation suggestive of central line tip in RA, positive swirl sign. So you can always document it, whatever evaluation you have performed. Now, another, so as you have picked up first case I would like to discuss, and I think this will create some interest because these are our stories from the department and they are really inspiring. So this was one patient who was posted for elective cesarean section in some nursing hospital, and after an uneventful spinal anesthesia, patient developed profound hypotension. So the exact cause was not known, and they tried managing in that nursing home the hypotension element, but they were not very sure about it. And in that hypotensive state, the surgery was abandoned. It has even not started. So they just said, we haven't done anything. It was anyways elective LSCS. So then the patient was shifted to our institute. And I was on call, and even the investigation showed that it is a TROP-T positive now, because a lot of hypotension and they were not able to treat it properly. And now the obstetrician told me that the patient is in active labor. So now it's not an elective LSCS, now it is an emergency LSCS. So you have to rush. So now with this type of a situation, I was really worried about the patient, and the patient was getting shifted. So we did a Pocus intervention for this patient, and we really looked at the IVC. When ejection fraction is on the lower side with a TROP-T positive patient, probably nobody will give that much of fluid. And we have done an IVC guided fluid management. I have given almost 1 liter of fluid. Then we placed central line, art line, and then it was under general anesthesia. The baby was delivered, everything. And then in the end, we could extubate. What I'm trying to suggest is if you have an acute MI patient with a history of acute MI and then emergency surgery, probably very few of us would have that courage to give fluids. Now here is a goal-directed approach, and looking at IVC, and you can definitely manage it very well. Now coming to position 2, apical 4-chamber, this is here the ultrasound probe is placed near the 5th intercostal space, and you see the 4 chambers, the RA, RV, the LA and LV. You can see mitral valve, you can see tricuspid valve. The size of RV and the size of LV, you can compare it. So if RA, RV is dilated, it is probably we are suspecting pulmonary embolism or something. Now this is LA and LV. And you can very well see the morphology of mitral valve here. Sometimes when we have patients for labor analgesia, suddenly there can be murmur, and whether we can put an epidural or not. So putting a probe there, and if you could see mitral stenosis, or even in other views I'll be showing, you can pick up aortic stenosis. You can refer them, or you can ask for a cardiology reference. So this is very well seen here. You can lower down, see a descending thoracic aorta, and that's the descending thoracic aorta. Any fluid above the descending thoracic aorta is pericardial effusion. Anything below is pleural effusion. So as we have seen, so I'm coming to second case. This has happened with us, and these were the initial days where we have started robotic surgery. And this was a 70-year-old VIP patient, diabetes, hypertension, IHD with EF of 40%. And robotic surgery has started, almost 1 hour has gone, and suddenly there was a flat line. So these were few initial cases where everybody was apprehensive. The surgeon said, "Oh, I have not done anything. What has gone wrong?" And everybody was looking at each other. And because of that VIP syndrome, there was a chief intensivist and a cardiologist inside the operation theater. And what we could do, I just got the echo machine and we could show this image. This was an old image where RARV was dilated, and we could record them and we could show them. So the cardiologist and the intensivist were so convinced and they were so happy that the diagnosis is settled, the anesthetists are fantastic, there is absolutely no problem. And then it was picked up as a CO2 embolism, and we treated the patient, and then surgery got over and the patient was extubated on third day. So once we know the diagnosis, we feel very confident, and images can be stored. You can have expert opinion on that, and it is a very good idea to develop a scientific approach to our anesthesia methodology. So coming to position 3 is parasternal long and short axis, how we do it. And we just place the probe in second and third parasternal area. And what we see in the long axis is on the top is the RV, then we have LV. So LA, LV, and then the opening of aorta and aortic valve. So in this view, we see mitral valve, we can see aortic valve. So morphological assessment, if there are any vegetations, we can also see lower down the descending thoracic aorta. So any pericardial effusion, pleural effusion, even this view is used for assessment of EF calculation. It can be used for assessment of E-point septal separation. So LV function can be assessed very well. This is a very useful view in patients where other views are not possible, say a female with a larger breast. Just putting a parasternal long and short axis will give us good idea. So coming to this view, you can very well see the mitral valve, the aortic valve, the RV. This is the short axis view when the probe is rotated 90 degree. This is a parasternal short axis view, mid papillary, the two papillary muscles nicely contracting. So you have a kissing ventricle, if it is a hypovolumic patient, you can have D sign of pulmonary embolism with a dilated RV, and you can pick up many other things. Even you can see the vascular supply very well, LAD territory, RCA territory, L6 territory. So you can pick up if there is any myocardial infarction in that area. Now coming to this, after knowledge of this position 3, I will just introduce you with another case. So this was a 76-year-old female, and this was diabetic hypertension, and this patient was for PTBD. And they said some sedation and then the procedure can be done. And patient suddenly developed chest pain, and there was a SVT run for around 10 seconds. Now, this patient was managed by a consultant who was a fellow from our institute, Dr. Sanghamitra Ghosh. And she happily reported this case to us that, sir, very well, we are trained in basic echo. So we could pick up that it was an acute myocardial infarction. And then the cardiologist was involved, and even, she calculated the ejection fraction, and she could see that EF has dropped from 60 to almost 35. And the cardiologists were very happy, and the diagnosis was picked up, and the further management can be very well streamlined. So even that confidence of the anesthesiologist, and they were asking from which institute you are trained and something like that. So it was pride and honor for us. Another small intervention which I would like to highlight is this use of color Doppler. Now in basic Pocus, we just teach the application so that valve morphology, and if there is any regurgitant lesion or a stenotic lesion, you can just freeze this image and you can just scroll it slowly so you can see those regurgitant jets. And it is very easy to identify if there is MR, AR, if there is any AS, MS, something like that. So you can assess. So I'm not going into higher details as of now, but even with eyeballing and putting color, you can pick up many good, morphology, assessment of valve morphology and changes. So artificial intelligence has come up in a very big way in echocardiography. I'm coming to end of my presentation, but I think Dr. Deepak has requested me to show this because this is really inspiring, and you can see how the era is changing. Nowadays, the machines will pick up not only the good view, if you have placed the probe, it will guide you. And if so, these red bricks, as you can see, these red bricks, it means the image is not good. It's poor quality. Now, and it is guiding you that, you should move the probe towards left, towards right. And if you have placed it rightly, it will immediately capture that and it will show it as green bricks and it will record it. And so it is guiding us to take proper views. It will record and it will analyze. So one good view and you will see EF is 59%, stroke volume is 54 ml, cardiac output is 3.6, and the heart rate is 66. So, this is the era of AI-enabled technology. So AI is guiding us where to place the probe. And sometimes as a beginner, we may struggle in putting all those measurements, holding the probe for longer duration. So even a small window of 2 seconds, you are picking up a good image. AI will calculate, it will capture, and it will record also. And it will analyze for you. So I think learning echocardiography is not difficult. I am sure it will be coming in a very big way. And these are some of our upcoming Pocus workshops. We, as I may be biased in saying, but we as a team AORA, and we are doing it one of the best Pocus workshop in the country as of now. So on 3rd, we have it in Ludhiana. On 5th October, it's at Ruby Hall as a part of state conference. On 21st and 22nd, we are in Mumbai, in Leelavati Hospital. On 3rd, it's a trauma event, and we have a Pocus workshop in PGI Chandigarh with Dr. Hari Kalagara also attending it. 10th December, we are conducting an advanced fate workshop. In Ganga, we have it on 18th of January, where we have a Pocus workshop and advanced masterclass. Basic and advanced Pocus masterclasses are also there. On 15th of Feb, we have it at AFMC Pune. It's a part of a national conference for neuroanesthesia. And on 25th, we welcome you all for AORA Hyderabad, where we have a totally parallel sessions, whole day sessions on Pocus, basic fate, advanced fate. And if you have not done any Pocus workshop with us, I would encourage, please do come. We do share, we share many case scenarios. We have many beautiful videos to share. And I think you will be very happy to attend our session. With this, I conclude. Thank you very much. If you have any questions, please do let me know. You can write to me on my email address. Thank you, sir. Thank you very much. Subbu, sir, over to you.
Thank you, Dr. Amit. It was a wonderful exposition of what all advances have happened in the bedside echocardiography. Please stand in for a second or two while the next speaker gets ready. Bala sir, while you are there as well, sir, either Amit or you, sir, should everyone start to learn about using bedside echocardiography? There are a lot of us who are young and not so young. In times to come, should everyone be learning? What are your thoughts, sir?
I think it's a joy. It's a joy to save a life, and it's a joy to learn a new thing. And I'm happy to say that when we started this, the ultrasound-guided fellowship programs, we were surprised. There was one applicant who was 74 years old. And we called him, sir, is it possible for you to do the fellowship? He said, why not? I have the mind to do it, and I have the physique to do it. I wanted to learn in my life. So when I die, I'll be happy that I've learned a new thing in my life, and this will save a life. So that is probably an answer to the question. I think it's the joy of detecting something by yourself is very, very good. And I think the world will be divided into two, those who know to use this lovely tool, the ultrasound, and those who do not. And I wish that by the end of the next 5 years, the whole world will have the power of having the probe in the hand of an anesthesiologist, which will save millions of lives across this world. And you know that initially everything looks gray, black and white. But the minute you start doing it, you start learning it. And I'm sure that it's not something very difficult to learn. Thank you so much, Subbu, for this.
Those are pearls of wisdom, sir. Amit, while Dr. Sunil Karanth gets ready with lung ultrasonography, how long did it take for you to pick up this skill and so-called confidence? When did you grow? How did it happen to you?
Yeah, so thank you, sir. I think as now there are ASRA guidelines, and I was just contemplating. I could see that if you follow the course very vigorously, it has a e-learning module and then 100% hands-on session, and then so just like ACLS and BLS, at the end of the day, you are trained to pick up that basic views, the basic 4 views, and all that advanced echocardiography depends on all these basic views only. So as we interpret that and get more and more, so what is the difference between a senior echocardiographer and a junior echocardiographer? So when we do echocardiography, our images are like a black and white old days Dynora TV, and whereas when a senior echocardiographer is doing it is HD LCD quality and all that. But somehow, even by just placing the probe, we are able to pick up basic, looking at IVC, looking at contractility. We may not get all the 4 views in all patients, but at least 1 or 2 good windows will suffice. And I'm sure the struggle continues, and with practice, we move on further and further. Thank you.
Thank you, Dr. Amit. There are a few questions people have posted on the forum. Please see if you can help that. And please stay online till the end. If we have time, we will take some Q&As at the end. So, Balasa, with your permission, may I invite Dr. Sunil Karanth?
Yes, of course.
Talk. And
yes, as anesthesiologists, the name that we don't like the most is hypoxia. So I think that's an excellent topic.
Yeah. Dr. Sunil, there's no other better person to talk to us all about how to use ultrasound for the respiration and lungs. Thank you very much. We are all ears now. Thank you.
Thank you, sir. It's a privilege to be part of the teaching program for the anesthesia teams. I'm a bit of an odd man out, but I do a little bit of anesthesia as a part of intensive care, but primarily a physician gone into ICU. With that apart, I think, as rightly Dr. Balavenkat sir said, you are also physicians. Perioperative physician is the new name. And I think essentially what all the previous speakers alluded to is very, very true. Ultrasound in the last decade and a half or a little more has actually revolutionized care of an acutely ill patient. Could be in anesthesia, emergency, or ICU. So I'll be talking about lung ultrasound in general, just to sort of get a brief overview of how it is. So historically, when I trained as a physician, the first statement in the Harrison textbook of Gospel of Medicine, which we all would have to study to pass the exam, said that ultrasound was a bad modality for the evaluation of lungs. But over time, we have learned to bypass this statement or circumvent it, work around it, and there is increasing popularity of ultrasound in its use in the acutely ill patient for a variety of reasons. Of course, the advantage is that there is no risk of radiation, but most importantly, the sensitivity it brings into diagnosing different kinds of pathologies in the lung, and also the certain degree of portability and very short learning curve that we spoke about. Now, some of the principles of lung ultrasound is that, of course, it is always good to have a simple equipment. In fact, when Professor Lichtenstein started lung ultrasound in the ICU, in fact, he even swears by it even now that he uses a single probe, which is a microconvex probe of about 5 to 8 megahertz. But the simplicity of the equipment is very important. What we play around with is the artifacts of the pathology, which is the gas and fluid sort of changes or opposite echogenicities that happen in different pathologies of the lung. And like the stethoscope, we define standard areas and use the pleural line as the reference line as we go deeper down into the tissues. And as I told you, the idea is to play with the artifacts that are produced by the pathology. And of course, based on that, there are characteristic patterns that are seen in different kind of broad pathologies of the lung. The probe that is preferred is the microconvex probe, which is about 5 to 8 megahertz. But for convenience, a lot of us do use the vascular probe, because microconvex probe is not a standard probe that we use in most of our ultrasonography studies. And it has to be separately bought. Or if you ask me which is the one single probe that we would prefer to use in a critically ill patient or in an acutely ill patient, I would say go for the microconvex probe, which kind of gives you the advantage of using it for ultrasound, using it for placement of lines, for lung ultrasound, and also for that matter, a gross overview of the echocardiography probe as well. But the bottom line that we need to understand is the minimum frequency that we need is a little over 5, between 5 and 10, and 5 to 8 is the best, but even up to 10 to 12 megahertz is preferred, because the frequency needs to be beyond 5. So a general cardiac probe may not suffice, or a megahertz of less than 4 or 3 may not be sufficient. Now, this is one of the methods that I have just picked up for ease of simplicity, but people have gone from this method to much more higher number of quadrants. But let us keep it very simple. So basically what we do is we divide the chest into 3 quadrants, as you can see. This is what is called as the upper blue point, the lower blue point, and the PLAPS point, which in full form is called as the posterolateral alveolo-pleural syndrome. So essentially what we do is that we place 2 of our palms on one side of the chest, the upper half of the chest by one hand, which is called the upper blue point. The midpoint of that is called the upper blue point, which roughly correlates to the mammary and the upper mammary and the subclavicular area or the infraclavicular area, while the lower blue point is the lower half of the chest. And from the lower margin of the lower hand, you draw a line, imaginary line, to the posterior axillary line, and that point is called as the posterolateral alveolo-pleural space. Now, this is a very important area, because that kind of reaches to the inferior most part of the lung or the pleural cavity, which is where most of the pathology often exists in most of our acutely ill patients. In fact, if you scan patients who have undergone a surgery for 4 to 6 hours, you put a probe there, it is very common to see either a little bit of an effusion or a little bit of atelectatic changes that often present in that area. Now, having said that, findings there are very common, but it may not be necessarily pathological in the sense, or necessarily contributing to problems. So most of our area of interest would lie mostly in the anterior part of the chest. Of course, in the critically ill patients, we have now advanced to even looking at the posterior part of the lung, or the posterior surface or posterior part of the body, which is the back, where also we divide the lung into 2 quadrants, and therefore we look at what is called as the 12 quadrant, or a 12 quadrant or a 8 quadrant system. But let us stick to this, which is a 6 quadrant system. So summary: upper blue point, which correlates to the upper hand or the midpoint of the upper hand, and the lower blue point, which correlates to the midpoint of the lower hand, and you draw an imaginary line from there to the posterior axillary line, which will correspond to the what we call as the PLAPS point. Now, some of the common lines or common pictures that we see are, one is called as the A line, which is nothing but multiple parallel lines which are equidistant from the pleural line, and they go deeper down, which essentially is nothing but artifacts coming from the pleural line. Now, this is a normal pattern that we see. B lines are vertical lines which run from the pleural line. That's why I told you the pleural line is a reference line, very important, which is the first parallel line that you get along the length of the or the breadth of the image, and from there you see multiple lines going down, so which akin to disco lights or laser lights that you see. These are all sort of tall lines which are minimum of about 5 to 8 centimeters, and they extend all the way down to 8 centimeters. Now, just remember this value of 8. I'll come to it as we move further, but these are what we call as B lines. So A lines are normal, which are nothing but they truly don't exist. They're actually artifacts which are reflections of the pleural line, and multiple of these lines you see equidistant from the pleural line, and you might see 3, 4, 5 and multiple lines which are parallel to each other, which are equidistant from each other. That's the A line, which is normal, and B lines, as I said, are vertical lines running from the pleural line downwards vertically, and actually they move with the pleural shadow if you actually do have a normal pleural slide. So if you take this normal representation of a lung, this is a picture of a normal view of a normal lung on how it looks on an ultrasound. We call it as a bat sign. Now you actually find two sort of acoustic shadows, which are nothing but the rib shadows which are seen, and in between that you actually find the multiple A line that I was talking about. So these arrows represent the A lines, and this is the two acoustic artifacts that I told you, which is nothing but the B line, which is nothing but the rib shadows. So this is how this is what is called as a bat sign, which is a normal which is normal, and then you have what is called as the seashore sign, which is again a normal finding that you see. So if you put an M mode on this particular area of the lung, you actually find that you have two different representations. This is the pleural line, and you have the movement artifact that you find here, which is the lung shadow or the lung movement, and this is the soft tissue shadow. So this is something similar to a seashore, and that is why we call this as a seashore sign, which is a normal representation of the lung. Now, this is how the lung would look on a normal videograph of the lung. You find that these are the two ribs, the rib shadow you can see below that. That is the pleural line, and this is the pleural line. And now if I put an M mode on this, you will actually find the seashore sign, which I depicted in the previous image. Now, at the PLAPS point, as I said, it's a very sensitive spot, and this is the first point of area where you actually find pathological changes beginning to happen. There could be the occurrence of a small effusion. There could be occurrence of small shredded signs, as we call, which is because of atelectatic changes or consolidatory changes that happen at that point of at that area. So the first separation of the pleural space, that is the visceral pleura, the parietal pleura and the visceral pleura, is seen as what we call as a quad sign. It's a kind of a square that starts at the PLAPS point, and that's why we call it as a quad sign. When you put an M mode, you actually find the sinusoidal wave pattern where you find that there is the lung which comes and goes, and there is a small space here which is separating the visceral from the parietal from the visceral pleura, and that is the early accumulation or early sign of a pleural effusion in the PLAPS point. Now, this is a kind of an image that is not very uncommon in the ICU, where you find that there is a lung, there is an effusion here, and underneath that the first representation of the solid organ, which is nothing but could be the liver on the right side or the spleen on the left side. Now, there are different kind of pictures or different kind of representations of what we call as a lung consolidation. The most pathognomonic one is what we call as the tissue pattern. This is nothing but a hepatized lung, where you actually find that S is a spleen, and you find that the entire lower lobe here is kind of very, very solidified, and there is very, very little difference in the echogenicity between the solid organ, which is the spleen, and the consolidated lung. This is not a very common occurrence that we see. We do see it occasionally, but when this happens, you are rest assured to say that this is a very consolidated, lobar consolidated lung, which is almost like the hepatized lung that we classically describe in pathology. And it is very important to be very careful here, because sometimes you might often miss the solid organ, which is underneath that with the tissue pattern of the lung, and you may actually say that this is the solid organ, or you may go the other way to say that this is the part of the lung. So it's important to identify this diaphragmatic shadow which is there. And many instances, we can actually, because of the solidification of the lung and absence of air in that part, you can actually see right down up to the mediastinal line, and sometimes even the pulsating great vessels can also be seen. The second classical sign of a consolidation is a non-translobar representation, which is nothing but the shredded sign. Some people call it the starry sky appearance, where you find patchy areas of whiteness in a distribution of black, which is very similar to, it's actually because of the interface of the air mucosal interface that happens in the areas where there is a consolidated lung and a normal lung. Now, these are something similar to the bronchopneumonic pattern that we used to see, but that was being described in pathology. And the third important sign of consolidation is what is called as the air bronchogram or the dynamic air bronchogram. Now, here what you see is a consolidated lung, and within that you actually find that there is, as the air moves in and out, or there's inhalation and exhalation that takes place, you're actually able to see these white patches moving in and out. Now, this is what is called as the dynamic air bronchogram, which is very pathognomonic, or what we call as a sign qua non representation of a consolidation. So these are the three patterns that we see with pneumonia or in patients with pneumonia. The second, or in patients who do have consolidation. The second pattern are interstitial syndromes. Now, as I said, there are what are called as B lines. Now, it's important to differentiate these B lines from what are called as comet signs, which are nothing but artifacts which are similar to B lines, but you find that these comet lines do not go beyond about 2 to 3 centimeters. So that's why I told you it's very important to ensure that these vertical lines extend from the pleural lines all the way down to about a depth of at least about 5 to 8 centimeters. And therefore, it is very important to have a depth of between 6 and 8 centimeters when we are doing a lung ultrasound, to ensure that we are differentiating a comet sign, which is only an artifact, from a pathognomonic B line. So if you have in a given lung field at least more than 3 or more B lines, then you would consider that as significant. If it is less than 3, then it is not significant. But if you have more than 3 or more B lines, or more than 2 B lines in a given lung field, which is jutting out from the pleural line way down to about a depth of about 6 to 8 centimeters, then you would consider that as a pathognomonic sign of a presence of an interstitial syndrome. It could indicate that there is interstitial edema, or sometimes even in interstitial fibrosis may occur like that. Basically, these are similar to the curly A lines or the curly lines that we see on a chest X-ray. But the important thing here is that these are very, very sensitive lines, and we use these sometimes when we are resuscitating patients in the ICU, or when using fluid therapy, because once we start getting B lines, then we know that we have crossed the limit, and we would be actually pulling back on the fluids when these lines start appearing, as compared to a previous study when there was no B lines. Now, as the B lines become more and more confluent, you actually call it as lung rockets, and you find that this is an indication to say that the intensity of the B lines is becoming more and more. So the septal rockets becoming lung rockets, indicates that there is increase in the interstitial edema. So this is a less interstitial edematous area, or less fluid in the interstitium. This is when there is more fluid in the interstitium. Now, one of the methods that we differentiate a cardiogenic pulmonary edema from a non-cardiogenic pulmonary edema is when you have B lines are present in both, but there could be a more of a symmetrical distribution of the B lines in the presence of cardiogenic pulmonary edema, as compared to a non-cardiogenic pulmonary edema, where the lines are asymmetrical. And often you find that there could be subpleural shreds, or shreds that are present in the lung fields, which, as I told you, what was the shred sign I told you in the previous slide. So that is one way that we can differentiate a non-cardiogenic pulmonary edema from a cardiogenic pulmonary edema. Having said that, in very severe cardiogenic pulmonary edema, it is not uncommon to get these kind of shreds even in cardiogenic pulmonary edema. But in the initial stages, this is one of the ways that we can use to differentiate a cardiogenic pulmonary edema from a non-cardiogenic cause, or what we otherwise call as ARDS. A Z line is another line which is important to differentiate from a B line. This is nothing but where we actually find that there is a comet artifact, and that's the pleural line, and that is the normal A line. So this is called a Z line, but this is a normal representation, and that's why I told you, as you can see, this comet artifact is not going deep down beyond about 5 to 8 centimeters. Now coming to, this is how a video would look of a pulmonary edema. You can see that's the pleural line sliding, multiple B lines or vertical lines which are going all the way down to the to about 5 to 8 centimeters, or all the way along the depth of the ultrasound probe. So that's why it's very important to ensure that optimal depth is actually maintained when you actually do a measurement of the B lines. Next important pathological signal or sign that we look for is the presence of a pneumothorax. There are 3 important signs here. One is the absence of pleural slide, absence of B lines, and what is called as the stratosphere sign. Now, if these 3 are present, then it has a very high sensitivity to say that there is probably presence of a pneumothorax here. Now, this is particularly true if you have a previous documentation in that lungs field, where you have actually found that there was a B line, there was a there was a sliding pleura. Now, if that disappears and there are signs to suggest that the patient has hypoxia, then if presence of these 3 signs would indicate that there is, or it predict that there is a pneumothorax underlying the in the lung, in that part of the lung which is underlying the probe. So how it looks is that the normal pleural slide disappears. You start getting on the M mode what is called as the stratosphere sign. And if there is presence of a lung point, which is nothing but I will show you in the next image. If there is presence of a lung point, you are 100% specific to suggest that there is a pneumothorax. So if you get a lung point, there is no question. You can be 100% specific or 100% sure that there is a pneumothorax underlying the probe. But if you have these 2 signs, it is very suggestive, almost 99% sensitive to suggest that there is presence of a underlying pneumothorax. Now, what is a lung point? A lung point is when you actually place the probe at the junction of the collapsed lung. You will find that on one half of the lung, you will find the collapsed lung coming and going, while on the other half of the lung, you will actually find that there is absence of lung slide and a stratosphere sign. So basically, if you're lucky enough to place the probe on the junction of the collapsed lung and the normal lung, collapsed lung and the pneumothorax, you will actually find that the lung comes and goes, and that is very, very suggestive to say that there is presence of a pneumothorax underlying that. So this is how a normal lung would look. You actually find that there is a lung which is fairly normal. You're finding the lung slide here as compared to the presence of a pneumothorax where there is no lung slide. So there is no lung slide on this, and you actually find that you compare the normal and the pneumothorax slide. That's how
recording stopped.
Now, on the other hand, if you look at this particular slide, you find that this is how the normal lung would look. And this is how the pneumothorax would actually start looking. So this is when you actually put the M mode. I told you the M mode, when you have the seashore sign here and the absence of the seashore sign, which is called as the stratosphere sign. Now, don't worry about the names. So basically what happens is that the pleural line disappears, and you actually find that there is these multiple bar signs, which are actually horizontal bars that start happening. So that's very, very suggestive to say that there is presence of a pneumothorax. Now, this is how a lung point sign would look. This is what I told you was the junction of the lung point coming and going, and that is that's the part of the pleural slide, where there is no slide happening. This is the sliding pleura. This is the part where there is no slide that's happening, and the part of the lung which comes and goes is what is called as the sliding part of the pointing lung point slide. So, in short, these are the different profiles that we see. I told you A profile is when you have normal anterior multiple sort of parallel A lines, which is nothing but the reverberating artifacts of the pleural of the pleura, which has multiple parallel lines which are equidistant from each other. If you find that there is absence of the lung slide or the pleural slide, then that is called as the A prime. Similarly, B profile is with all the signs of the B lines, which is you have the B lines which are extending from the pleural line downwards to the point of at least about 5 to 8 centimeters. Very important to ensure that these B lines go right across the vertical profile of the image. Otherwise, you would be actually missing it for a comet slide with comet line, which should have a depth of at least about 6 to 8 centimeters. Now that will become a B profile, and if you have absence of a lung slide, then it becomes a B profile sign, and the different signs of consolidation is called as the C profile. Now the Plapp's point, as I told you, these are all the different profiles that you will find, including the sign of effusion and also presence of the movement of a collapsed lung at that point of at the Plapp's point. Now, there are different decision-making trees, as the previous speakers also mentioned to you. The importance here is to ensure that the application of this decision tree is in the presence of a symptom, or in the presence, or to answer a specific question. Now, if you have somebody who is hypoxic, we use one of the decision-making tree called as the blue protocol, where all these different profiles are integrated, and you actually start with the first point, which is there a lung slide? If there is a lung slide, is it associated with a B profile or a profile? If there is a B profile and a lung slide, then it would mean there is a pulmonary edema, which means that there is a sliding lung with B lines, which is nothing but a pulmonary edema. If there is a sliding lung with the A profile and you are still having hypoxia, that means the lungs are normal. Then you start looking for other causes such as pulmonary embolism or presence of COPD or asthma.
Recording in progress.
If you have a by B profile or a C profile, it could indicate that there is a pneumonia. On the other hand, if you have no lung slide, which is called as a prime or a B prime profile, absence of slide with a B profile, it would indicate that there is a pneumonia. Absence of slide with either a lung point indicates pneumothorax. Without a lung point, you may have to look for other causes. Now, this decision tree has about a 90.5% sensitive accuracy to pick up different problems, and very, very rarely do we need to investigate beyond this in the intensive care setting. So some of the limitations of lung ultrasound is, of course, it is observer dependent. There is a possibility of misinterpretation, and most importantly, when there is a subcutaneous emphysema, this is not a very, very useful tool to use. So in short, ultrasound of the lung has come a long way in the last 1.5 to 2 decades. Today, we are even able to quantify lung ultrasound or quantify or to look to assess the fluid resuscitation, recruitment maneuvers. All these we use. We actually try to use lung ultrasound as a measure or as a bedside tool to look at the response to different kinds of therapeutic maneuvers on the ventilator and also during fluid therapy. Thank you.
Thank you, Dr. Sunil. It was a wonderful, lucid presentation. Bala sir, just briefly, why?
I think we lost the link with Subbu sir. Next is Devesh. Are you ready?
Yeah, just a minute. Let me share my screen.
Recording stopped.
Is my screen visible?
Yeah, it's visible.
Okay.
So, starting with the presentation, Bala sir, you want to add something? You want to share?
No, I think the lung ultrasound was very, very important, especially I think sometimes when you're confronted with hypoxia, it very quickly you can find out whether this patient needs a diuretic or not, which may completely change the whole scenario.
Recording in progress.
So the finding out pulmonary edema, finding out pneumothorax, finding out hemothorax, are such simple things which make a huge difference in preventing hypoxia and the consequences of that. And that was a brilliant talk. I'm very happy that those who are listening to that get an insight into the various uses of the bedside ultrasound.
Yeah. Thank you, Dr. Sunil, Karanth, and we'll move on with the next presentation. Yes, over to Devesh.
Good evening, ladies and gentlemen. At the outset, I'd like to thank Dr. Balavenkat, Dr. Subramanyam, Mahankali for giving me this opportunity to interact with this august audience. I'll be covering in next 15 minutes something about eFirst. So I bring greetings from Asian Hospital, Faridabad, which is situated in the heart of Delhi NCR. We are a 425-bedded multi and super specialty hospital, and we do a lot of academic work in the form of DNBs and the Regional Anesthesia Fellowship, which is from Academy of Regional Anesthesia. So these are my set of disclosures. I do not have any conflict of interest. You will be seeing a lot of images which are from Google. The references are from PubMed, and I'll try my level best to adhere to the allocated time. So what are the learning objectives for this lecture, my dear friends? We'll try to understand what is eFirst, how do we actually do it in our clinical practice, is there any evidence to support its use, and how to go about it as a beginner. So as a definition, it stands for Extended Focused Assessment with Sonography in Trauma, which is a point of care ultrasound examination. And we are trying to detect free fluid as well as some pathological conditions, either in the abdominal cavity, pelvic cavity, pericardial cavity, or the thoracic cavity, and with an additional ability to detect pneumothorax. So as has been used by various authors who have described previously, it's the IAM Framework, that is the indication, acquisition, interpretation, and medical decision making, which we use for all kind of focus examinations, and this is not so different. So what are the indications of eFirst? We are talking particularly in the context of trauma, and whenever we see free fluid in any of these cavities, we presume that it's blood. And we are having an additional ability to detect pneumothorax because, as it was said by Dr. Kirkpatrick in 2004, that we are adding an extended element to the fast examinations. But does that leave that we do not have any non-trauma indications? The answer is certainly no. So we have many non-trauma indications, my dear friends. We can diagnose any hypotension which is of undifferentiated origin following abdominal surgery or ectopic pregnancy, or there is an abdominal aorta and it is a rupture. And we can do a quick fast examination, abdominal ultrasound, and diagnose any cause of urinary retention. And particularly in hip arthroscopy cases, we have intra-abdominal fluid extravasation, which leads to nausea, vomiting, which can be easily diagnosed. As I take you through my presentation, I'll be telling you representative examples where we have actually used this modality in our perioperative period. So how do we acquire image? So in order to acquire the image, we need a supine patient, and we have to ensure that the hands are raised above the head of the patient. And for right upper quadrant and left upper quadrant views, we need a head-low position so as to increase the sensitivity. And for pelvic examination, a head-up view is desirable. And the operator stands on the right side of the patient. And since we have to do certain calculations, we have to freeze the image multiple times. The ultrasound machine has to be on the same side so that we can manipulate it very easily. And we use a curvilinear probe because all the structures are deeply situated, except for pneumothoracic evaluation, we have to use a linear probe. And the aspect marker has to be for all longitudinal examinations toward the head end of the patient and towards the right side for the transverse examination. Is there any particular sequence that we need to scan? There is no, we have defined sequences, but in context of relevant trauma, for example, if I have a patient who is of suspected thoracic trauma, then I can straightforward start with the lung as well as cardiac examination. But I have a patient who is of suspected abdominal trauma, the best, highest quality yield view is the right upper quadrant view. Then we shift over to the splenic side, then the pelvic, then we finish up with the cardiac view and then evaluate for a pneumothorax and a hemothorax. So let's come on to the first and the most important right upper quadrant view, which is defined as the high yield view, because this is the most dependent portion of the upper half of the peritoneum where blood actually collects. So as I said, we need a head-low position. The probe is placed in the mid-axillary line between 8th to 11th intercostal space. Just draw a line parallel to xiphoid process and place a probe in the mid-axillary line. You will be correct most of the times. And the aspect marker is towards the head. So what is the problem generally we face? We get to see the rib shadows. So if we turn the probe counterclockwise, parallel to the intercostal view, then we get a good image and we can obliterate these arterioles. we follow a rule of three, my dear friends. We are trying to identify the diaphragm, the liver, and the kidney. So, and we are trying to look for fluid collection in three important places in between the diaphragm and the liver and the kidney, and above the diaphragm. So this is how a hemoperitoneum will look like. The fluid first starts to collect from the caudal tip of the liver. We have to ensure that we fan the probe generously anterior to posterior and cranial to caudal so that we do not miss any area. Once blood collects here, and as the blood collection becomes more and more, other spaces will get flooded by the liver, by the blood. So coming on to the another view, which is a left upper quadrant view, it is technically more challenging to obtain as compared to right upper quadrant view because the spleen is located more posterior and it is slightly higher. So we need to place the probe on the posterior axillary line and ensure that our knuckles are touching the bed. And we need to place around 6 to 9th intercostal space. And in order to obliterate the rib shadows which can trouble us, we have to turn the probe clockwise in this case, so as to place the probe parallel to the intercostal space. So again, rule of three follows. We have to follow the diaphragm shadow, the spleen, and the kidney. We have to remember one important thing, that on the left side, we have a phrenicocholic ligament. So blood will not start to collect first in the splenorenal space. It will collect in the perisplenic space first, and you have to evaluate that. We cannot say it's a negative fast just looking at the space between spleen and the kidney. So again, as we follow the rule, we have to evaluate in all three dimensions and do a generous spanning, and this holds true for the left upper quadrant also. After we finish the right and the left upper quadrant views, it's generally advisable to slide the probe cranially so as to look for the fluid in the costophrenic space, and which in context of trauma would imply that it is a hemothorax. So diaphragm, my dear friends, would appear as curved hyperechoic line superior to the liver and the spleen, and generally because diaphragm is quite refractile, so it will cast a mirror image artifact of the liver and spleen if there is no pleural effusion. And you have to evaluate for the movement of the lung, which is known as the curtain sign, which will come and abut against the diaphragm. So any collection which happens will obliterate this mirror image, and you will be able to see the spine in the thoracic cavity.
Recording in progress.
Normally, spine is seen in the abdominal cavity. It's not seen in the thoracic cavity. If there is a fluid collection, which could be pleural effusion or hemothorax, the spine would be visible in the thoracic cavity, and which will reflect that this is a case of pleural effusion, which in context of trauma would be hemothorax. So after we finish these views, we come on to the subcostal view. When we are performing EFAST examination, we are using a curvilinear probe. We have to take care that the aspect marker for performing a cardiac examination, in this case, would be pointing towards the right shoulder. We place the probe in the subxiphoid area using a corkscrew grip or overhand grip, and the aspect marker, as I said, towards the right shoulder, which we have to be very careful. So fluid in the pericardial cavity would appear as hypoechoic or anechoic collection. So in case if we are not able to obtain a good
recording in progress,
good crisp view, we can increase the depth, we can apply a considerable degree of pressure, and we can ask the patient to take a deep breath. In spite of that, we are not getting a good view, we can change over to the cardiac probe, or alternatively, we can take a parasternal long axis view, which can also demonstrate a pericardial effusion, which in context of trauma would be hemopericardial. So this is how a normal four-chambered subcostal view appears with a curvilinear probe, and any fluid collection can be seen anterior or posterior to the cardiac shadow. So coming on to another view, which is the pelvic cavity view, we have to evaluate pelvic cavity both in the longitudinal axis with the aspect marker pointing cranially, and then turning transversely with the aspect marker pointing towards the patient's right. We have to remember that free fluid can collect anywhere in the anterior cavity, posterior, or lateral, and a generous fanning of the probe in horizontal and longitudinal direction is recommended. So how does a male pelvic cavity appear when we try to insonate it with the ultrasound probe? This is how it appears in the transverse view. We see the bladder, we see the prostate, which has a mixed echogenicity. Posterior to that would be the rectum, And we can see sometimes the seminal vesicles, which can be a confounding factor. And as a novice, we can mistake it as a collection of fluid, and we can think that it is a free fluid collection. But we have to remember that it's a fluid-filled structure, seminal vesicles. It's present on both sides. It's posterior to the bladder, and it casts a shadow, an appearance which is known as a bow tie appearance, and it is got a fixed location. If we generously fan the probe in superior and inferior direction, we'll come to know that whether it is a seminal vesicle or a true exact free fluid collection. In longitudinal view, we can see the prostate on the downside, and bladder would appear like this. This is a diagram where it shows ultrasound picture, the free fluid collection in the rectovesical pouch and the Foley's catheter in situ. So how does female pelvic cavity appear on an ultrasound view? We have to understand now that there is a uterus which is interposed between the bladder and the rectum. So this is how a longitudinal view would appear. This is how a short axis view would appear. Now the fluid will collect in the rectouterine pouch as it is shown. We have to remember that in menstruating females, we have some kind of physiological fluid which will in the long axis occupy less than 1/3. If we divide the long axis of the uterus as upper 1/3, middle 1/3, and lower 1/3, it will occupy less than 1/3, so that we do not mistake it as a free fluid. So coming on to the urinary bladder evaluation, my dear friends, we can use the urinary bladder evaluation for measuring the volume, diagnosing stones, mass, and clots. But since we are doing a point of care ultrasound examination, we are more interested in the volume, which we can measure in the transverse scan using the length and the width, and in the longitudinal scan using the height. And the formula which is used is 0.75 length, width, and height. And as Dr. Amit has said, modern day machines are AI equipped. They can themselves calculate, and we need not use this formula. So right now we have studied the various views. How do they help us? I'll try to narrate two cases which happened to us very recently. We had done a major abdominal surgery and we had shifted the patient to the ICU. Half an hour afterwards, we get a call that patient is almost hypotensive. So I went and they were trying to resuscitate. And immediately I suggested, let's put a abdominal probe. And then we realized that a lot of fluid had collected in the Morrison's pouch, and then immediately took the patient inside the theater, and we realized that the ligature had slipped off a major vessel. This is how it can help us in our day-to-day practice. We do a lot of renal transplant patients. The recipient had been closed, and then we realized while before extubation, we have a tendency to see whether there is a urine flow or not, and the urine flow was almost absent for last 10 minutes. So we immediately put a probe, and we realized that bladder was distended, but there was no flow. So then we called the surgeon, and he immediately started the irrigation. And then we realized there were a lot of clots which had blocked the catheter, and the catheter had to be changed. So this is how we can use this modality in day-to-day perioperative purpose. So coming on to the last view, that is for detection of pneumothorax, which has been very well covered by my previous speaker. I will not go into much details. So how urgent you have to perform, my dear friends? It has to be done within 3 minutes, and it is operator dependent. So you need 30 level 1 studies. That means where the studies you have personally performed and interpreted, and 20 studies where you have not performed, but you are interpreting. So in totality, you need 50 studies to gain sufficient proficiency. This was the same reference which was quoted by Dr. Amit. So generally, it can be performed within less than 3 minutes. So now coming on to an important aspect, how do we actually go about it? You have actually studied the various views. Now you have the findings. Now actually, how do we go about it? So it's very simple. CT is the gold standard. But in case the patient is unstable, FAST is positive, take the patient for emergency laparotomy. But if the patient is stable, FAST is positive, do a quick CT so as to find out other pathologies along with it. This is the pneumothorax flowchart, which has been discussed in great detail by my previous speaker. I remember by the mnemonic systolic blood pressure, that is S stands for sliding, B stands for B lines, and P stands for lung pulse. If they are absent, and then we can have a lung point, which is a pathognomonic sign of pneumothorax. So now coming on to the clinical pulse, my dear friends, EFAST is a test which has got a moderate sensitivity, 60 to 80%, but a high specificity of 99%. So my dear friends, it is a good tool to rule in free fluid, but it cannot be used to rule out free fluid. And serial EFAST examinations improve the sensitivity. And we have to remember there can be false positives as well as false negatives. So how do we start EFAST? As we know, the initiation of any Pocus modality is difficult for anyone. It was difficult for me, but I'll suggest you small things. We have to take baby steps and take a step-ladder approach, my dear friends. We should be knowing the anatomy and the sonoanatomy, which I've already elaborated to you. Do not try to see each and every view in one setting. Always consolidate one view at a time and then proceed to another. Scan volunteers, scan patients under GA, because normally surgeons do take some time to wash and then prep and drape. And if you're working in an ICU setting, go there and try to scan the effusions and the pneumothorax. And whenever you get a blunt abdominal trauma or any ectopic gestation patient, try to scan and then we get a good hands-on. So I have tried my level best to cover. And in case you have still more appetite, these are set of references which I have used. And I would request every one of you to go through these references. So in summary, my dear friends, it's easy to learn, perform, and teach. It's essentially a bedside examination. It's non-invasive and it's quite safe and it can be quickly performed and it is quite repeatable. And the best part is it does not involve exposure to radiation and it provides real-time imaging.
Thank you, Dr. Devesh. Bala sir, you mind exploring a couple of questions, and I will share my screen by that time.
Yeah. So I think that was an excellent exposition. And as I said, this is extremely useful in trauma settings where it's really life-saving, which I mentioned to start with initially. And also the EFAST, the extended EFAST gives an idea when you have to go and put an ICD and then see the pericardium and then see the bleeding inside the abdomen. So as we know in trauma, which we our hospital, which we see a lot, I think primarily this is an excellent bedside tool and a life-saving tool to make sure that we identify what's happening inside the traumatized chest and traumatized abdomen and the retroperitoneum. Thank you so much, Dr. Devesh, for taking us through a nice journey of knowing the various facets of EFAST.
Shall I start the next talk, sir?
Yes, please. Yeah.
Good evening. I don't know, most of you might be having a dinner plate in your hand. It's probably just post-dinner time. And it's something, related to that. My talk is related to that. I owe a lot to these two institutions which are there on the screen. At the top, the AIMS and the Queen's Medical Center, Nottingham. This is where I learned most of my basics, and the below is where I'm currently working. Now, in this talk, basically, I just want to go through and explore with you all why should we use gastric ultrasound, how to perform it, how to assess the contents. Can we assess the contents at all? And what is the structured way to look at it? And can we use it in all populations like children, pregnant women? And framework, we saw the IAM framework, which are absolutely the same here. And we'll see how to go about. Now, one of the important fundamental things about this topic is why do we need to do gastric ultrasound? Is there a need? So, because aspiration is something very individualistic to specialty of anesthesia. So, the important question for us is to know whether is the stomach empty or not. If we are assured the stomach is empty, we don't need to do gastric ultrasound. We can proceed with the way we have planned. But as it happens, so many times we don't have clarity whether the stomach is empty or not. At those times, what we need to do is we need to do gastric ultrasound. That helps us to make decisions. So in this talk, I'll tell you which part of the stomach to scan for and how to identify the patterns of solids, how to look at how the liquids look like, how the semi-solids or liquids looks like, and accordingly how to plan your anesthesia and make sure that the patient comes out safe after the surgery. No. Did we use this assessment before? Did we use any way of assessment? Yes. We have been very passive in assessing whether the patient is full stomach or not, whether there could be stomach content in the stomach or not. But all these were based on patient's words and a little bit of understanding about background medical condition. But what we now has a powerful tool right in front of us, that which helps us actively, objectively assess whether there is content in the stomach or not. So basically, I'll help you identify the patterns as we go through. But if you look at what I can say is, we have made life very, very structured. There are number of conditions which pose difficulty for us. We have made it simple. We have identified risks. We stratified the risk, and we have taken risk reduction strategies. But unfortunately, we didn't have one till recently. But now with gastric ultrasound, even for the pulmonary aspiration risk, we can have a stratification tool. What complicates us is, we know, yes, there are times when stomach emptying is unpredictable, but there are a number of medical conditions which make the stomach emptying delayed, or even after a presumed fasting of such a duration, patients, the stomach can still have contents. Along with it, we have conditions which are painful, which delay the gastric emptying, trauma which delays the gastric emptying, and there are a number of medications which also delay the gastric emptying. All this would mean that probably we will have a lot more patients where the stomach emptying is not assured, even at the end of normal recommended fasting. So stomach may have contents which can have an impact on our perioperative airway management. All we need to do is any ultrasound machine here, the basic to the advanced one, you can use them to do the gastric ultrasound. I will show you where to go, what to about. Now, while doing gastric ultrasound, the important part where we are looking at is the gastric antrum or pyloric antrum. Why? Because that is the last part of the stomach to get emptied. So in this picture, as you see, in the pyloric antrum is marked there. That is the area where we are looking. We are not looking at body. We are not looking at fundus. The only area where we are analyzing is the gastric antrum. That gives us enough information to assess whether the stomach has contents. If so, what is the content? In a sense, what we are doing is we are identifying the stomach, the pyloric antrum, in a structured way. And what are the structures? We will slowly see. Okay. And also, is it easy to identify the pyloric antrum? The answer to that is yes. The pyloric antrum has a very definitive appearance, and that appearance you will see in the next few slides. And it is possible to identify the stomach definitively by identifying the pyloric antrum. Depending on what it's there, we have a reasonable estimate what could be the content in the stomach. What you need to do in a gastric ultrasound, basically you put your probe in just below the Xephod process, slightly to the left of the median, slowly sweep it to the right. When do we stop? When we see the pulsations of the aorta. In essence, what we are doing is we are putting on the body of the stomach and slowly pushing the probe to the right. So that we'll stop the probe when we see the aortic pulsation. How it looks, what is appearance, I will go through. But most of the time, which transducer is useful for us? It's the curved array probe, which is useful for us. And maybe in small children, we can use linear high frequency probe, but most of the time, it is the curved probe which is useful for us. In essence, what we are doing is we do gastric ultrasound in two positions. It's recommended in two positions. That is supine and right lateral. People ask me, sir, what should you do if patient cannot turn right lateral? So the answer to that is you can make it simple by giving it slightly head up tilt so that whatever air is there in the dependent part of the stomach goes away and whatever contents is there in the stomach comes down. In that way, it helps us assess what is there in the stomach. Okay. So when you put the probe, most of the time, what we see is this gray and white shadows. Now, if we directly look like, where is the stomach, it will be difficult to identify. So if we go through a structured process from one end to the other end, we will be able to identify each part of what we are saying. Let's say, for example, in this video, so we can see we start from skin, and then below the skin is subcutaneous tissue. The muscular layer is below that. And you can see the big liver there, which is moving with respiration. And we saw the aortic pulsation there. The big branch of the aorta, this SMA is also there. And there we see the shadow of the bowels, the transverse colon there, and the duodenum pancreas there. Sandwiched between the liver and the duodenum pancreas is our antrum. It's almost always in that position. It's fairly easy to identify whether the individual is thin or obese, and all individuals have found it's fairly easy to identify, right? The same video here, if you look at it here, are you people able to recognize the stomach? Are you people able to recognize the gastric antrum? Yes. And also you look carefully at the antrum. It has got a typical appearance, right? I'll show you the next slide again. Now after identifying the pyloric antrum, what should we do? There are three kinds of assessment which can be done. What is known as a qualitative assessment, semi-quantitative, and quantitative. What does it mean? Qualitative is about character. So you look at it whether to say whether you have the contents or not, it is empty or not. If the contents are there, is it solid, liquid, or semi-liquid? That is the qualitative assessment. In semi-quantitative, what we do is you do assessments in two positions, that is in supine and right lateral, and see whether the contents are there in both the positions. That gives us an assessment whether the risk is high or not. And quantitative means you go and assess what is the actual quantity. For example, what is your height? It could be 175 centimeters. In that way, you can know exactly, approximately, you can estimate the residual contents in the stomach. Okay. Now let's see how we go through about all these three assessments. In the qualitative assessment, you look at the picture, you store the image, save the image, and look at it whether it is empty, that contains solid or fluids. How the appearance looks like. For example, here in this picture, you can clearly see the stomach is completely empty. In that rounded red arrow, red circle, you can see the gastric antrum has a typical appearance. You can see a hyperechoic outer serosa and between muscularis, and then inner part which is slightly mixed echogenicity because of the gastric rugae, or where the mucosal folds are there. All this makes it the appearance of the stomach very characteristic. This appearance is there in almost all of them, but when the contents are there, the appearance slightly differs. Let us see how it looks like. For example, if the liquid is there, you can see the outer wall is exactly the same. In the middle of that circle, you can see it has become hypoechoic. That is the appearance of the clear fluids when you have clear fluids in the stomach. Now, for example, how does the solids look like? We all chew the foods. All the solids, when they go into the stomach, they mix with the acid and they become like a thick paste. And this is the appearance of a thick paste appearance, not a semi-solids or solids appearance there. This is the appearance of a where the solids are there in the stomach. Now, people ask me, sir, what should we do? If we find the solid, should we go on to estimate? The moment you find something like solids in the stomach, that means your Pocus question is answered. Whether the stomach is full or not is answered. The presence of solids means that it's high risk. So you can take whatever is appropriate for that particular case. Now, I talked about semi-quantitative, didn't I? So what does it mean? So with qualitative, we saw identify the stomach, freeze the image, and look at the content to say whether it is empty or solids or liquids, right? Now, in semi-quantitative, what you do, at any point of time you see solid, it is qualitative is done, it is high risk. But in case if it's semi-quantitative you want to do, you do assessment in supine and right lateral. If something is there in the supine and right lateral position, especially liquids, then you probably can consider them as slightly higher risk. But if liquid is there, small quantity liquid, only in the right lateral position, it's probably still safe to go through. People think if it is there in both the positions, that is supine and right lateral, the residual content is likely to be more than 1.5 ml per kg. That is more than 100 ml in normal 70 kg adult. So it is quite likely that the risk for aspiration is higher. But if it's there only in the right lateral and not there in the supine position, that means it's probably less than 1.5 ml per kg. That means the risk of aspiration is probably low, even though you can find some liquids in that. This is the semi-quantitative assessment of gastric content. Okay. Now, quantitative means what? As I told you. So it is about estimating almost the actual quantity, what is there, the residual contents in that. So for example, if I ask you what is your height, you will say 175. Weight, the same thing. Here, the same way here, you are estimating the content based on a few parameters. Again, the process is same. Identify the stomach, identify the pyloric antrum, freeze the image. And once you freeze the image, you measure the cross-sectional surface area of the gastric antrum. And people have worked on this, and they have given mathematical models wherein which if you put the age and the cross-sectional surface area, you can actually estimate the residual content in the stomach. It's a validated formula, validated tool to answer the question. So they have found evidence by doing the gastroscopy and aspirating and assessing the contents. It's been validated in different age groups, and as as well as in pregnant ladies. This slightly different formula is also being worked out. There are a couple of different ways, but this is probably the most popular formula wherein which you can do a quantitative assessment of the stomach contents. Right? What do we do in gastric assessment? In this case, if you look at in this picture, the stomach is dilated. You can identify the hyperechogenic or the gastric appearance of the antrum wall, and within that is mixed echogenicity. Lot of solid contents is there. Actually, you don't need to do, and the formula is not valid if the solid content is there. But if liquid content is there, if you think it's liquid, you freeze the image, estimate, and you mark out with the tool what is the circumference, measure the cross-sectional surface area, and you put it in the equation. You will get a value. That area, which is the 16.6, is the area. And you put that in the equation, you will get what is the amount of residual content in the stomach. Okay. So anything more than 75 to 100 mils is considered as a high risk. With this, in case you want to know, plenty of studies have come out whether after fasting patient still has some contents. People with problems like CKD, they have residual content more than this. Generally, it is thought 1.5 mils per kg is acceptable, beyond which is the risk of aspiration can be high and the consequences can be quite drastic. Okay. In a sense, the summary of gastric ultrasound is you first start with identifying the stomach and take the images in supine and right lateral. So you do a qualitative assessment. In the qualitative assessment, you look at the picture and decide whether it is solids, liquids, or empty. If it's empty, safe to proceed. If solids are there, clear cut. This is the Pocus examination stops there. It's high risk for aspiration. If liquids are there, you see whether the liquids are there in just only the right lateral or both in right lateral as well as in supine position. If it's there in both the positions, it's probably slightly higher risk. Then if you want to really go and estimate and publish, send for publication, you can do a volume assessment of the residual liquid content in the stomach by using standard equations. Okay, is that clear? Fine. Before I finish my talk, there are a few good images which I want to show you. Please go through this carefully. It will help you when you start scanning these images. Okay. Now, for example, in this here, you can see the gastric. It's a completely flattened out target appearance is there. The stomach is completely empty. You can see the mucosal folds touching each other. Okay. The next thing is, if let's say you see here, there is a little bit of content in the stomach, a little bit of mixing with the air. It's what we call a starry sky appearance. Okay. Now, with the frosted glass appearance, it describes when it's late solid contents are there mixed with other. It's more like a paste. It's the classic frosted glass appearance. Okay. Next view is this is the appearance of the stomach in a 1-year-old child. I don't know how clearly you're able to view. You can see here the liver, below the liver, the entire stomach, the gastric antrum is being seen, as well as the gastric folds there, right? As well as the gastric fold, gastric mucosal folds are clearly seen in this. This 5-layer appearance is characteristic. It's very well visualized when you're using a linear probe. Okay. Now, again, as I told, there's a plenty of usefulness of this. Whenever a patient is septic, even though it's fasted, I have started to scan them, and I find a lot of them still have the content in the stomach. So if there's content in the stomach, I would definitely not choose LMA as my choice of airway. So that helps me decide whether should I put an LMA, even though it's a short case, should I go for tube, and if so, if I have to sedate, can I go for deep sedation, etc. Right? Now, this is the appearance of a fully dilated stomach when there is a small bowel obstruction. Before I finish, it's a sequential scan. Please go through this slowly, one by one, the image, which will let you see how the images appear when an individual or a volunteer is made to fast, given liquids, given solids, how it looks. Okay. This is a volunteer who has fasted for nearly 8 hours. And they can clearly see, identify the stomach, identify the mucosal folds, and we are at the level of the aorta, right? Now, the next image you can see, he is fasted for more than 8 hours. Slowly, we made him turn right lateral. I can see this little bit of contents coming in the middle of the stomach there, right? In supine position, it was completely flattened out. But in right lateral, a small amount of content is coming with peristalsis. You can see the movements, okay? So this is fairly normal. In most of the individuals, after fasting, particularly it will be there. But the content is likely to be less than 1.5 mils per kg. Now, the same individual, when we gave him a carbohydrate drink and assessed in the supine position, you can see the appearance of stomach has changed. This hypoechoic and mixed echoic is starting to appear. When we turn right lateral, you can see it slowly gets bigger, and the antrum dilates, and with peristalsis, you can see sudden gush of fluid into the pyloric antrum. Okay. Now, after 2 minutes after drink, when the air has gone out, you can clearly see it expands so much like a balloon that you can almost estimate the content. It was almost matching with what he had. Now, after giving a carbohydrate drink for some minutes and after giving a solid food, again you can see the appearance of the stomach is completely changing from hypoechogenics to mixed echogenicity. And after solids, it even gets, you can see that the ultrasound beam is almost being stopped there. And it looks like, frosted glass are completely not allowing any of the ultrasound images to pass through. Now, finally, you can see in the right lateral position, the stomach is hugely dilated, filled with various grades of digested content in the stomach. And do we need to estimate the quantity here? No. The fact that it is appearing like that means that the stomach is full, and we need to take every precaution we need to ensure that we protect the airway, right? If you want to estimate, you can freeze the image, calculate the surface area, and go on to estimate. Okay. Now, of course, after every examination, you should make sure that you are identifying the gallbladder as well. In workshops, you will find how to identify the gallbladder as well. Okay. In summary, what I want to say is gastric ultrasound is there to act as a powerful aid, and it's fairly easy to do. All you need to do is do it under supervision or get experience of around 15 to 20. The theorists say that you probably need around 25 scans, but once you get that scanning going, once you have that expertise, believe me, it's going to be a powerful tool in your hand, wherein which you can make very clear-cut decisions. What is your airway management plan? So how to go about deep sedation? Can we use which kind of airway to use? You can have a clear-cut plan and come out as a winner at the end. If you have any questions, please do post it to me or on the forum or through this WhatsApp or email. I will be very happy to answer. If you want these images, I'm happy to share it as well. And good luck. Thank you very much.
Thank you so much, Dr. Subramanyam, for taking us through a journey of how to do ultrasound, and especially for anesthesiologists when you're confronted with a full stomach, no stomach. And does this mean that all the existing guidelines will vanish of the fasting guidelines, which are part of several organizations which have given fasting guidelines? With the advent of ultrasound, this 2 hours, 4 hours, 1 hour, 6 hours, do you think everything will disappear and it will become more evidence-based and you go by case basis? What's your thoughts on this, Dr. Subramanyam?
Sir, whenever we have this, acts as an additional tool which helps us see inside actually what is happening. So already we have started to see that there is revision in how patients are fed. For example, in pediatrics, which was 4 hours and 6 hours for breast milk, etc., and clear fluids 2 hours, they have come down to 1 hour. Because the half time of the stomach, theoretically, we always knew the half time of anything in the stomach, liquids, is 15 minutes. And we all knew for nearly 30, 40 years that by around 45 minutes, the 3 half times, the content will come down to less than 15%. But we were always worried. But now we have objective evidence. At the end of 1 hour, the stomach is almost empty. So, and that is the kind of powerful evidence at the hand which can help us. Yes. And also I feel, for example, we all know pregnant ladies are always hungry. They want to eat. They are hungry. They keep eating frequent small meals. But the regulation says, no, the stomach is always full. Now, should we believe the guidelines that no, each stomach is always full? Or the patient saying, I'm hungry? At 2 or 3 hours, they are hungry. That means the stomach empty. So we have a tool in which we can look at it and see whether the stomach is empty or not, and take an objective, valid decision based on what we are finding.
Okay, thank you so much. And if the newcomers are using it, what is the sensitivity and specificity of the volume calculation? Would they be right most of the times, or are there any studies which have done to show the accurate measurement of the gastric contents and the volume?
Sir, as I said, there are 3 things, particular aspect here, sir. One is whether the stomach contents are there. That is qualitative assessment. Most of the time, the qualitative assessment helps us make a decision. Now, when we come to quantitative assessment, where the liquids are being there, And most of the studies have been in volunteers or patients who are going for gastroendoscopy, etc. So they have a very, very high accuracy, sir. More than 95% accuracy has been there. People are trying to get it to a single value, but as I said, if there is any, all these equations or formulas are validated for liquids and assessment done in right lateral position only. If you take that measurements and say in supine position, I had this volume, it is not validated for supine position because we are looking at the most dependent part of the stomach in that particular position, and that has to be calculated. That if it's done, that is fairly accurate, I feel.
Excellent. Okay. Thank you so much, Dr. Subramanyam. I think it was a treat to listen to 5 different talks on some of the essential components of bedside diagnosis, which will give a clue. There are a few questions. There is a question, Dr. Amit, there is a question they want to know about the hands-on workshop for basic and advanced echo. I think you had already mentioned, but you can probably just enumerate the ones which you're going to do, both basic and advanced echo.
Yeah, so regularly we are doing basic and advanced echo, and as I have highlighted the Pocus workshop calendar, we do include basic FATE in all our Pocus workshop. But nowadays, after doing basic FATE for quite few times, there is a need for advanced FATE workshop as well. And so on 10th December, we have planned it in Pune. So please do write to me. I have texted my email address. I can guide you in person, and we can definitely find a way out. Yeah.
Thank you so much, Amit. For Dr. Madan.
Bala sir, there's a question which probably you can, when you can add clarity, sir. Now, one of them has asked if, as anesthetist, can we report these findings? I know lot of newer things have been adopted in Ganga at your place. For example, let's say we are doing all these tools, airway, ultrasound, and cardiac, all those things. Can we give a report on this? So, what are your thoughts, sir?
So actually, not only the report, the surgery itself is done based on the finding. So report becomes secondary. And of course, you are documenting whatever you're finding in the case sheet. And it's an accepted modality here. So I think the institutional practice has to be established. And the admin also should be taken into account so that there is no conflict of thoughts. I think patient-centric policies have to be evolved at institutional levels. What is easy in my institution may not be possible in a multi-speciality place. So there should be an acceptance, and the net goal is very effective treatment done at the earliest.
So, sir, we were asking some question to Dr. Madan, sir.
Yeah, Dr. Madan, I just wanted to know, are there any studies to show, especially in pediatric age group, pediatric intensive care especially, what kind of endotracheal tube to use, even if they want it to be ventilated for about a few days? Because we are very concerned about a subglottic edema and post-extubation spasm. Are there any review articles or studies which continuously monitors them in the intensive care unit to find out or prognosticate this possibility?
Dr. Madan?
Dr. Madan, can you unmute yourself? As Dr. Madan is coming out, there is a question from Dr. Anju Gupta to Dr. Divesh Arora. In a eFast, would you like to go? What would be the sequence of your propositions?
The sequence which is generally recommended is that you start from right upper quadrant, then shift over to left upper quadrant, then pelvic cavity, then subcostal, and then the anterior.
Dr. Anju's question is, after right upper quadrant, is it better to go to cardiac and then go to the left upper quadrant?
It will all depend on the context of the trauma. For example, if we are looking at abdominal trauma, then we shift from right upper quadrant to left upper quadrant. And if we suspect a major thoracic trauma, then we like to start initially from the subcostal window and jump to the thoracic window and then come back to the abdominal window. So the case history is of much more importance rather than going with a fixed pre-notion that I'll scan this area first.
Okay, thank you so much, Dr. Debesh. One question is, what is the validation of fluid therapy using the IVC dimensions? Question can be taken by any of the panelists.
Yeah, Dr. Karanth is today with us. Definitely, it's a big answer, but I am also interested in knowing from Dr. Karanth.
Yeah, so IVC, I think, has lost its importance in fluid management of late, especially when they are on self-ventilation or on a mode where they are triggering the ventilator. I think the short answer would be, if it is very, very low or the IVC is less than 1.2 centimeters, it is very sensitive or more than 98% sensitive to suggest that there is hypovolemia. But anything which is more than 1.2, collapsibility is not very this thing. In a ventilated patient, it may still hold at 60 to 70% sensitivity, but otherwise, I think it has no role. So IVC itself, I think only if it is very, very small is predictive that the person is going to be fluid responsive. Else, I think we have to take it with a pinch of salt or in combination with other things.
Yeah, so now we have this LVOT VTI, and many of us are using auto VTI, and we have even cardiac output as one of the parameter where we assess. So these also, most of these patients do have ABG and lactate levels. So taking into account the whole clinical picture, we can be in better off.
And VEXUS also helps us these days, especially with the portal vein, hepatic vein. I think renal is a little far-fetched sometimes. Most of the time, I don't get it. So because to get into the intraparenchymal vessels is a little difficult. But on a given patient, actually, if you are able to serially track, you know roughly when it's time to stop the fluid. And that's when the tissue congestion part comes into the picture as well. So I think instead of saying in between patients, for a given patient, a trend always matters.
Yes, and some of the viewers and aggressive Pocus interventionist, they believe that VEXUS should be added as VEXUS L. You also look at the lung, and if there are B lines, and then probably we should stop. So always good idea to look at lung, heart, and correlate accordingly.
So I think to answer that question, I would say, as Dr. Amit rightly put, when we talk about hemodynamic variables, we have to always look at a host of variables and the patient's condition. I think that should be the take-home point. We can't look at one variable or two variables. So it should be forward flow, backward flow, tissue congestion, all put together. Then you come. And if sometimes that is also not enough, you may even have to look at dynamic. It is like the passive leg raising and such other things. So it's saying it's a holistic thing that we need to look at.
Last point, sir. Just what PG has gained interest in Pocus is because we just showed them how we do EFAST and everything, and then there was one patient with not much of urine output, and he just placed the probe on the the bladder, and bladder was full, and the Foley's catheter was blocked. So this is something very simple thing, and we are thinking that there is no urine output, and Pocus can help in the bladder is full. So let us reposition it, something like that. Thank you.
Okay.
Well, sir, maybe something you can help all of you also participate. One interesting question here, sir. Do we need some certification from any institute or any radiology department for validation of our diagnosis?
I think it's very premature to answer this question because anything that we are going to commit now should get a concurrence from the authorities who do it. As of today, I think it's more of a tool which is helping us rather than trying to, is validated as if there is some medical council saying that, yes, a report can be given by an anesthesiologist, because this will produce a lot of controversy, and there could be a tussle between specialities. So I think at this point of time, we would consider this as a tool which is a companion for easy diagnosis and early care, rather than going into the legal aspect of it, which may deter several people from doing it and utilizing it appropriately.
So true, sir. I'll share one small
Yes.
anecdote, sir. For example, around nearly 7 years back, I picked up the gastric ultrasound topic, and when we picked up the topic, the ethics committee initially asked, we involve the radiology team so that what we are seeing, because it's fairly new, let them help understand how the stomach looks like, identify it, etc. But after around 5 times, we were looking more convincing than that. They stopped it. But now it has happened in the last few years. The other institutions, when they are given a topic of gastric ultrasound, they instead of referring to their own radiologist, they refer to me. Can this person come under you, train for a week, and go back so that they know what they are seeing? So slowly, I think credibility of what we are doing is spreading. So I was glad to see that the other institutes are referring to anesthetists rather than asking the radiologists, because we are interested in this. They are not bothered about this. So the focused expertise, whether it is gastric ultrasound or airway ultrasound, it's coming because we are interested. We are developing the knowledge. So, and in the same way, I'm sure when people like Amit are doing more and more perioperative echo, I find we'll be more interested than anybody else. So
Exactly.
I think in the same anecdote, like diastolic dysfunction was very much an intensivist's sort of finding or anesthetist finding, because they would just not report diastolic till about a decade ago or about 8-9 years ago. Now, I think having told them repeatedly, the cardiologists now look for it. But that used to be one of our largest reasons for why people used to fail getting off the ventilator.
Yeah. And the reporting aspect, I just would like to add one more thing. Previously, we were also, in two minds, because this dilemma of report or not to report. But what we have started doing now is we just put it as a heading as a screening echo or limited echo evaluation, and we put it on the paper, because in subsequent management of the patient, the other anesthesiologist who is following up with that patient, they do have some definitive idea that yes, previously that IVC, they have looked at IVC, they have looked at contractility, and these were the initial findings. So it gives some amount of guidance to them, and that opportunity should be given with good documentation. We are not competing with any cardiologist for any report, but whatever we are doing, we are putting it as minimal echo evaluation or screening echo or something limited evaluation study. I mean, panelists can decide over that, but I think more and more, even in ICU, they have started writing down very shortly what are the positive findings, like that. Yes.
Yeah.
Bala sir, it may not be the last, but I have one question I want to ask. Will anesthetists can ever fight for a right to use ultrasound for diagnostic focus purposes? Can we have, in the US, as a body, they have moved towards anesthetist has got a right to use ultrasound for focus evaluation. So in any way, in the future, is there anything we can do that we can also have a right to use ultrasound as diagnostic focus?
See, actually, as I said that you started teaching gastric ultrasound more than the radiologist, because it was identified as your core strength. So it becomes important for us as a specialty to represent our capabilities to the National Medical Council. And when they understand that, yes, these specialists are able to do this equally or probably better sometimes in areas where normally the radiologists do not focus, and there is no need to focus for them. And so when we as an organization and as a specialty represent our requirements most appropriately to the National Medical Council, I think it's definitely a possibility that once they understand that this adds a lot of value in patient care and also in safety, I think the day is not far away. It all depends on us, on how we communicate, how do we represent our specialty. And I think I'm very confident that we should be able to accomplish this in the next few years.
Thank you, sir. Any closing words from any of the faculty will take?
Yeah, I think number one, I wanted to really congratulate all the 5 panelists for bringing in their expertise and a brilliant exposition of what they can do with this wonderful tool. And fortunately, now it's available in most of the medical centers, including the institutions, including the government-run hospitals. This ultrasound machine has become a component of the emergency room and the operation theatre. So I think our patients will be richly benefited by this. And I would like to thank OCARD, Mr. Venkatraman, who has been the one who's been handling all of our webinars with such grace and Ellen. Thank you so much, Venkat, to you and the OCARD for giving us this platform all the time and every time that we have asked. Sincere thanks for that.
Always a pleasure, sir. Thank you so much.
Thank you so much. And it was very nice to start with introductory remarks from Dr. Tushar Choksi, and also the number of delegates. I think at one point of time there were 600 plus delegates watching it through the Zoom link and also through Anesthesia TV, and that's very, very heartening that we were able to share this knowledge. And any last word from any of the panelists, and then they would close.
I think as anesthesiologists, if we are using ultrasound for performing regional anesthesia, transition to the Pocus should be the next step, and we should not hesitate in doing that. This is what I did in my practice, and slowly I'm evolving as a Pocus expert. And I rightly agree with Dr. Subramanyam said that people will refer cases to us that you are certified in that. And in fact, I was discussing with my radiologist about gastric ultrasound a few days back. Actually, they were not also much aware. So they were just requesting me, please enlighten us. So I got enlightenment about abdominal aorta ultrasound from them. So this is how we can increase each other's knowledge.
Absolutely. Well said.
Just to add, I just want to tell some of the trainees that this is a complementary tool. Remember, it's not a replacement to your clinical assessment, judgment. So this is to sharpen your skill rather than use it as an alternative. I think that is something we have to understand, because it should not be that instead of giving a chest compression, I will start pulling the ultrasound machine. I think that should not be.
Yeah, true. Well, very well said. Yeah, thank you so much, Doctor.
Dr. Amit, do you have any comments?
No, it was a really wonderful session, and I think we have energized a whole of audience, and we can see that from all the questions. Congratulations to you, sir, Bala sir. Thank you, all the panelists. We really enjoyed this wonderful session. Thank you.
Thank you all. Thank you.
So
Sir,
thank you so
I'll leave
much.
the last word to you. Sir, I'll leave the last word and thanking to you. Before that, what I personal feeling is that a lot of structure has come into how we can use ultrasound in our perioperative practice in the form of Pocus. A lot of focused assessments have developed, and we are in a critical stage where the machines which are available are compared to 2 decades back, these are fantastic machines which help us actually use those tools effectively in our tool. And even though things like cardiac ultrasound, echocardiography looks difficult for us, people like Amit are making it easy for us. And we not only have inspiring webinars like this, we have certifying workshops wherein which at the end of the workshop, there is a level of certification which is given that he has done safely 20 ultrasounds or 30 ultrasounds, echocardiographies. And I think we are moving towards a way wherein which we get certified and maintain the certification for echocardiography, and that will be the way forward. And wish you all happy focusing.
So, thank you so much. And I take this opportunity to welcome and invite all of them to the Ganga Anesthesia Refresher course, which is between 18th and 21st January, where there will be a lot of answers to all the questions that were asked. There is a full-day workshop on point-of-care ultrasound. There is mini workshops on transthoracic and transesophageal echo, 3 hours each throughout the conference. There are master classes on point-of-care ultrasound and also echo. So it's fully studded with upscaling our skills. So kindly do visit our website, www.ganga GARC, GARC, India.com for online registrations. And once again, my sincere thanks to all the panelists for the brilliant session. And we look forward to meeting again in a platform to learn from each other. Thank you so much to all of you. Yeah, bye.
Thank you all. Have a wonderful night. Thank you all.
Yeah, thank you. Thank you so much. Bye-bye.
Recording stopped.
Thank you, sir.
Yeah, bye. Well done, Subbu. Thank you so much.
Thank you, sir.
Thank you. Thank you, Rahul, sir, for telecasting in Anesthesia TV. And thank you, Venkat, for being a part of us all the time. Thank you, Dr. Madan. Thank you. Good night. Bye-bye.
Good night.